Good evening, everybody, and welcome to the second edition of Advanced Retinal Clinics, Understanding the Underlying Molecular Basis. Last week, we saw a lot of conditions that affect the adult retina, and this time we are going a step further and looking at those different conditions that affect the pediatric retina in particular, a lot of them with a genetic base, a lot of them with molecular basis as well. I welcome you all, and along with me today as the moderator is Dr. Arka Subraghosh. He's the chief of our Grow Lab at our facility, Narayan Nethralaya, in the Hosur Road branch. Over to you, Arko. He will introduce our panel, and then we'll take it forward.
Thank you, Chaitra. Welcome, everyone, to this second session of our Retina Clinics. So today we have a very distinguished panel and distinguished speakers. So I'm looking forward to some enthralling discussion and listening to some fantastic talks. So I'll start with introducing Professor Shomi Bhattacharya. So he's well known throughout the world of ophthalmic genetics. He is currently the Emeritus Professor of Experimental Ophthalmology at University College London. And he has been working for over 4 decades on various inherited ocular disorders and discovered more than 25 new loci. And a lot of us, a lot of our professors have also been trained by him. So we welcome him to the panelists. Second, we have Professor Govindasamy Kumar Manikkavel. He also is a very renowned geneticist and has been working for the past 25 years on ocular genomics, mapping a number of genes, doing mutational screening, particularly in the Indian context, especially in glaucoma and diabetic retinopathy. And he has also been mentoring a number of young ophthalmologists as well as basic scientists over the years. Then over to you, Chaitra.
So we don't have Dr. Jalali as yet. I'm sure she's busy. She'll join us very soon. Dr. Subhadra Jalali has done her MBBS with distinction from the Jammu University and a MS ophthalmology from PGI Chandigarh, and she was the silver medalist for the first order medal. She's also done her 2-year fellowship in general ophthalmology, including 1 year in retina vitreous services at LV Prasad between 91 and 93. She's also worked at the National Eye Institute in ocular genetic diseases and electrophysiology of vision and ocular inflammation and uveitis. So she's just the right person to be with us today. She has over 650 presentations and 170 publications in national and international journals and many book chapters. As soon as Madam joins us, we will welcome her again. Along with that, I have Dr. Deepankar Das. He's the head of the Department Ocular Pathology and Uveitis Services in Shankardeva Nethralaya in Guwahati, India. He has a specific interest in retinoblastoma pathology and its molecular pathological understanding. Welcome, Dr. Deepankar, and thank you for joining us. And next, we have Dr. Roshmi Gupta, who's trained at LVPI, and she heads the Orbit Oculoplasty and Ocular Oncology Division at Narayan Nethralaya. Dr. Roshmi also will be joining us in a bit. Over to you, Arko.
And then we have Dr. Indrajit Kaur with us. She comes from LV Prasad Eye Institute. She is quite well known in the ocular and vision research field in India, particularly working on a variety of molecular signaling and genetic projects across a number of diseases. So welcome, Indrajit. I think Roshmi has joined.
Yeah, welcome, Dr. Roshmi. We just did a brief introduction about you. She's the heads our plasty division at Narayan Nethralaya. Welcome, Dr. Roshmi.
Thank you. It's a pleasure to be here. Looking forward to this.
So, Arko, we can start off.
Right. So today, for our first speaker today is Professor Andrew Webster. So Andrew comes from the Institute of Ophthalmology at UCL, London. And there he has been a professor for a long time, working on a variety of retinal diseases. Now, during these past few years, we've had contact with Andrew through various means with the help of Shomi. And our own retinal dystrophy specialist, Purna Chandra, has actually had the chance of working with Andrew. So I'll let Purna tell a few words about Andrew. Purna?
Thank you, Dr. Alko. So it's a pleasure introducing Professor. So Professor Andrew Webster is trained in ophthalmology and genetics from Cambridge, USA and London. So Andrew Webster is a chair of molecular ophthalmology at University College London and a consultant ophthalmologist at Moorfields Eye Hospital. So he leads the genetic services at Moorfields, the largest specialist service in the country. So his research team has discovered genetic mechanism that underlie any retinal dystrophies. So Professor Webster has more than 400 research works and more than 10,000 citations and more than 6,000 reads. So it's again, welcome you, Professor Webster. We are very happy to listen from you, and thank you very much for agreeing for the invitation.
Thank you. So it's an honor to be here. Can you hear me?
Yes, we can hear you. Yes.
So it's an honor to be in Bangalore, virtually at least. So I'm going to share my screen now. So let's see if that works. So I've been finding out where Bangalore exactly is on the map. Does that work for people?
Yeah.
Okay. So I think I've got 25 minutes, haven't I? So Arka or Porno or whoever, just stop me when it's ready to stop. Otherwise, I'll just carry on. So you must stop. And I'm happy to. There's a number of us here, and I'm very happy to have questions during the talk if that might help. So I work at, as Porna has said, I work at Moorfields Eye Hospital. I know Shomi very well, who works around the corner at the Institute of Ophthalmology. This is Moorfields. It's a very different place now to usual, and I'm sure that's the same where you are. It's a very quiet building, and we're having to cancel non-urgent cases still since the end of March. And we're trying to work around that with virtual consultations and deferring people. It's going to be an interesting time. But now I do see adults, I don't see children. So this is exclusively an adult presentation. But there were children once, and some of the conditions I show present in children. So I'm going to talk about inherited retinal disease, which is my thing, and the challenge in diagnosing the precise cause of that and how that's changed recently. So Shomi and I are both old enough to remember the old technology that we used to make the molecular diagnosis. And that was very different. It's been revolutionized now through next generation sequencing. And throughout the talk, I'm going to be showing cases. Now, it's always good to define the topic of your talk. And so this is my definition of a retinal dystrophy, a monogenetically determined retinal dysfunction and or degeneration. So AMD is a retinal disorder due to genes, but it isn't a monogenetic disorder. It's due to many genes. So these particular disorders exclusively have one specific gene underlying them. And if we find that gene and we find the variants in the gene that cause the disorder, we immediately know a lot more about it, and that can be helpful. Other genes might affect the expression of the primary gene. They're modified genes, and we're yet to understand those. These disorders, retinal dystrophies, are symmetrical, although female carriers of X-linked forms of disorders are different. They're not symmetrical. That's an exception. They usually lack inflammatory signs. Inflammatory disorders can mimic retinal dystrophies. We call those phenocopies rather than misdiagnoses. It's a nicer term to use, phenocopy. And they can be congenital, so stationary disorders are congenital, such as achromatopsia and night blindness, foveal hyperplasia, developmental abnormalities of the retina are congenital. If they're not congenital, they're of slow onset, and that's a differentiating factor from other retinopathies that can be confused with dystrophies. So it's important also to know what isn't a retinal dystrophy. We always have to be aware of drugs. Retinotoxicity can mimic dystrophies. And autoimmune retinopathy, a very difficult condition to diagnose precisely. It's usually a diagnosis of exclusion from the clinical presentation. But that also can look very similar, and I'll show you an example of that. Whenever we suspect immune retinopathy, autoimmune retinopathy, we have a low threshold for searching for cancers. And increasingly now we're finding underlying early pre-symptomatic cancers that are detected and are likely to be causing or precipitating the immune response to the retina. Chorioretinitis can often look like a retinal dystrophy. I've got a number of folks with previous TB in which they look very similar to retinitis pigmentosa, but aren't, and they haven't moved for many years. And mosaicism can present like RP affecting one eye, for instance. So this is a case of a bullseye macular dystrophy. I show a lot of autofluorescent images. I find these particularly helpful in my practice, delineating the diseased retina from the normal retina. And also, it's a bit like looking at the rings of a tree. It gives you a history of the degeneration that's happened over years and how quickly it's happened. So this is a maculopathy, which could be genetic because it's very, very symmetrical, but people may recognize that as chloroquine retinopathy. And this lady actually took chloroquine when it was thought by mistake for many years she was taking hydroxychloroquine. But we know that hydroxychloroquine can do this too, but less often and to a lesser extent. And this is a lady I saw who had a disorder which looked as if it affected the RPE, much like choroideremia and other disorders that affect the RPE. But she had mellaril toxicity. She had a long history of taking mellaril, thioridazine for acute, for depression, severe depression. And that's something that can also mimic dystrophies. This is a more recent case that looks like adult vitelliform dystrophy. So this is a young man with a normal retina, acuity is just below normal on the Snellen chart, still able to drive with these symmetrical lesions, yellow-looking lesions in the fundus, and they're hyper-autofluorescent where the fovea is. And that's due to those little disruptions of the outer retina at the fovea. It's not adult vitelliform dystrophy. It could have been. Sometimes we can get deposits that then dissipate and leave a space under the retina. But this is proper retinopathy. This is something we see in Britain. It's not severe, but it's due to inhaling amyl nitrate and similar substances. This is just a case that's illustrative of getting the diagnosis right. This is a lady, 35 years old, a case that was managed by my colleague, Darnes Thomas at Moorfields. And she, when she presented, had recent field loss with shimmering lights in the area of field loss. And it was a quick presentation. So over a year, she'd been having these symptoms. And it had been changing quickly for her. And this was her right eye towards the end of the course of the disorder. And this is an autofluorescent imaging again, an OCT. And this sort of pattern we see in RP. This right eye could be from someone with RP, although the autofluorescence is a little messy than it would normally be for RP. But this lady had a disorder that progressed very quickly with shimmering lights, loss of field, zones of her field were lost. It was pretty acute. It affected the outer retina, as you've just seen from the OCT scan. And these autofluorescent images show the progression of the disorder. The bits that are affected are brighter. They're brighter because the photoreceptor outer segments have been lost acutely. The RPE still is putting out as much autofluorescence as it would normally do, but because there's less absorption from the opsins, it's brighter in the diseased retina. And so you can see it marching around the retina. And in the end, in 2017, in April, that bottom left slide, it really does look like RP. But it's asymmetrical. It breaks the symmetry rule. In the left eye, there was an area that was also affected around the disc and in the temporal retina. And she had immunosuppression. We don't know whether that helped her. We've got no contrary experiment to show, but we did our best to prevent the further degeneration. Now, why then seek a molecular diagnosis? Why does Show Me have a job? Because he was involved in discovering many of these genes to allow us to make a diagnosis. Well, even though we can't treat people yet, we're only starting to treat folks with RPE 65 now. We're hoping to treat people in the future with a similar approach. But confirming the molecular diagnosis, even without that, is helpful to patients and families. It gives prognostic value to people. It confirms the segregation pattern. We can give accurate risks then to members of the family. Without the diagnosis, we can't, because there are so many different ways in which these can segregate, with few exceptions. It can unmask syndromic disorders, and it's the only way to push forwards knowledge for clinicians and scientists. and the patient very often just can cope with a cause of their blindness if it's understood than if it's a mystery. But we have to temper people's expectations and make sure they don't think that a molecular diagnosis means treatment. They often do. They want to think that. If you find the gene, you can treat me, doctor. Well, of course, it isn't the case. It's challenging, though. There are many different genes. For each gene, there can be many different alleles that can cause the gene to either not work at all or have a toxic effect or in dominant disease. And genes can be very heterogeneous in their presentation. Sometimes they can just affect the retina, and other times they can affect the general other systems. And this is a recent trawl of our cases, which has just been published in Ophthalmology, looking at a cohort of people presenting in 2 years to the genetic service. And although there are many genes, we had 131 genes diagnosed in patients. A number predominate. So for fellows and residents, if they know about ABCA4 causing macular disease, and USHA2A and rhodopsin, and perhaps RPGR causing RP, that will cover the majority of cases that they'll be faced with in clinical practice. If you tap a patient on the shoulder in my clinic at random, then and bet they've got ABCA4, then there's about a 1 in 3 chance you'll be right. This is the first case, just to illustrate the allelic heterogeneity. So this is a gene which can be mutated many different ways. And Shomi is old enough to remember this being discovered and contributed to the discovery. So a lady in her 40s presented with night blindness in her 20s. It's helpful to get a history, and it's helpful to ask people when they first notice night blindness, because that can be discriminating with regard to the type of gene. And this one doesn't always cause congenital blindness, and I don't think it did in her. She had no memory of difficulties in the dark at school when playing outside with kids. She was diagnosed having RP in 25 years old, and that was relatively early because she had a family history, so it was suspected she might have the disorder. Her mother, maternal cousins, and if we sketched out the family tree, it was likely to be autosomal dominant with multiple affected generations. And she had to stop driving, but her acuities were still preserved. And again, I use autofluorescence as the most helpful way of getting an idea of the extent of the disease. And this is almost like a field of vision. In morphos, we don't tend to do fields because they take so long, but you can see the delineation of the degenerate retina here. So she will have areas of inferior nasal field that correspond to that supratemporal sparing. So it's symmetrical right and left, but it isn't symmetrical up and down. And we see this in this gene quite often. Sometimes it can be sectorial and just affect the inferior or the nasal distribution. And she's got a bit of edema. So if we did an OCT scan, we would see that those little petaloid hyperautofluorescent bits are due to cysts in which the light shines through the photoreceptors and gives rise to that appearance. And edema is quite common in these conditions. And we see an area, this is RP, of course, and in RP, we see an area of hyperautofluorescence, which delineates the normal field, at least for cones. So she will see at the posterior pole here, but she won't see much out here. And this is down because it's been going on a long time. So the RPE has less lipofuscin in it because for very many years, decades really, the RPE hasn't been phagocytosing outer segments. They haven't been there. They've died away. So this is, people might have guessed this is rhodopsin, the first gene to be discovered to cause RP back in 1990. That's a long time, 30 years ago. This is one of many mutations. This isn't one that's common in Britain. She's of an African background, and we've seen this in a couple of African families. And I find diagrams like this is from Marcus Pricing, Retina International, just to show the complexity of the mutations that can happen in this G protein coupled receptor. It's the most prevalent protein in the retina. So you don't have to perturb it much for it to cause a toxic effect on photoreceptors. Now, this is just to show that some genes can give rise to a different phenotype, and that can be confusing to fellows who are learning this business. And this is an example. This is an example discovered by Shomi's group back in 1993. And we see it now, and it's quite interesting. So this is one gene giving rise to two phenotypes. So these are two patients with a dominant family history. The first is a 50-year-old man with progressive loss of his peripheral vision, night blindness, but normal acuities in both eyes symmetrically. So that history in him really can only mean a gradual demise of the rod photoreceptors, that is retinitis pigmentosa. And the second patient, she's younger, she's 21, and her history is the opposite. She has perfectly good peripheral fields, symptomatically and objectively, but she's lost her central vision gradually. And her ERGs, which would be non-existent in the 50-year-old man, in her are full. So if we do a full field ERG with cone and rod responses, it is normal. And these are the two cases showing the opposite problem. So in the right eye of the gentleman at the top, he's lost all his peripheral retina. This is all degenerated. He sees nothing out with that central less than 10 degrees of field. Whereas here, this lady sees everything, but she's struggling with her acuities because it's the central retina that's affected. Is this gene something that people would, Porno will get this, I know, because we swap WhatsApp messages of these patients often. This is basic, but people may know this. And this is RDS peripherin 2. So this is a photoreceptor gene, and they're just two different missense changes. These patients are heterozygous. They've got dominant family histories. So somehow this particular perturbation of the gene, in one, it's a missense change, which we recognize well, arginine to tryptophan, and in the other, it's an in-frame deletion. So it's a deletion of one cysteine, and they're in different parts of the protein. But they have very different effects. One affects rod photoreceptors, and the other appears to affect the macular RPE. And the rod photoreceptors do fine in that second case. And that's just another diagram from Retina International that Marcus Pricing has put together. And this was the discovery. So RDS was initially found to cause RP, but then later Shomi's group showed that actually it can cause a very different disease with macular dystrophy. And we see more of the latter than the former cases now. This is a more recent, interesting difference. This is another gene that I see commonly in my practice. So these are common genes so far. So these are two men that I see in clinic, and they're born in the same year, but they've had very different stories. So the first case, so he's myopic, worn spectacles since a boy, but had completely normal vision from his point of view until his 40s. And then he presented to us in his mid-40s. He had difficulty seeing the detail of low contrast targets. However, he didn't like bright light. His peripheral vision was normal. He was a driver, but what stopped him was the ability to read a number plate, not his field of vision. A man exactly the same age had a different story. He's short-sighted, had reduced night vision and peripheral and central visual loss at school before he left school at 18. And even junior school he was affected. He never was able to drive. He was registered blind, severely sight impaired in his 30s. And when seeing them recently, his acuity was hand movements. And those are the two cases. So the man that presented in his 40s with loss of central vision at the top, he had electrophysiology. We could measure responses when we shone a flash of light at the eye. And it was affecting the cone's responses more than the rod responses. His rods were pretty good. So a dim light on a dark adapted eye was normal, and the bright white flash on a dark adapted retina, which mostly looks at rod photoreceptor function, was also pretty good. He had no pattern ERG, and we knew that he had no macular function. Whereas the other case had no recordable ERG at all, cones, rods, or pattern ERG. And it's the same gene that causes the disorder. And I just wonder whether Porno's not allowed to answer these questions because he'll know the answer. If we were to look at the daughter of the second more severe case, but not the daughter of the top case, we might see this. Neither of them actually had daughters that I've examined, but I know the way it works. The more severe case affects women this way, and this is a tapetal reflex in a carrier of the disorder affecting the two men. And with autofluorescence, you can see these radial hyperfluorescent appearance, which is pathognomonic. It's very specific to carriers of X-linked RP. And it can be RP2, it can be RP3, RPGR, more likely the latter because it's more common. So it's a very specific test, not necessarily sensitive. We don't see it in all of the female carriers.
Yeah. So do you advise electrophysiological test in these suspected carriers, the X-linked carrier which showed the typical autofluorescence pattern? So how often you advise electrophysiological evaluations in suspected carriers?
So in this young lady, probably not. But later on, it gives us a good baseline of their function. So I tend to do it. In people with severe retinopathy, and carriers can have a severe retinopathy, there's no point in doing it. So in the second case below, this is a bit of a fib. I know it's non-recordable. We haven't actually done it for very many years. He had one done when he was younger, and it was non-recordable then. But we don't bother doing ERG in a case that's typical RP. It's very helpful in this chap, and it was helpful to get the diagnosis because we know that this gene, RPGR, can give rise to these two phenotypes in men. One, the severe RP, which is more common, and that's what was known initially. And in those patients, they lose central vision early as well, compared to rhodopsin families, in which they tend to keep their central vision. That's the one phenotype, which is more common. The one that was a surprise to us about 10 years or so ago was this one, a cone dystrophy that just affects the central retina later on in life. And the carriers of these mutations, which are further downstream, they're in a different part of the gene, so we can predict this phenotype from knowing where the mutation is, whether it's at the end of the gene, at the end of the exon 15, and if it is, it's likely to give rise to the top phenotype. If it's within the repetitive region of all 15 or earlier, it gives rise usually to the bottom phenotype. And this is another female carrier who's a bit older, 40 years old, and she breaks the symmetry rule in that it looks a bit messy. It looks a bit more like old chorioretinitis or periphlebitis, but it isn't. This is a typical way we see a carrier females. She's got an early change. Now I've got 3 minutes left. So, okay, I'm going to wrap up soon. I've shown some cases. These have been, I've got enough to give another talk, obviously, really. But we're able to do this now because of the change in sequencing. And I think the one slide that's what I was doing with Show Me when I was working in his lab. It was very laborious, Sanger sequencing, a little bit at a time. And nowadays we do this, next generation sequencing, where we have many millions of these sequences in parallel. And each of those can give rise to that much of Sanger sequencing. And in a typical experiment, we use the Illumina platform. We'd have 300 million of these clusters, each generating 150 times 2 paired end reads, which would help us greatly. And we had some early experience of this with the NIHR Virusol study and the genomics England study. Arka, I've talked now till 1:28. So is it time for questions?
Right. So, well, you could take another couple of minutes if you want to finish this part of it.
Okay. It's important we still, although we can do the sequencing now quite completely, and the sensitivity of diagnosis is between 60 and 70% when we apply whole genome sequencing to a case of retinal dystrophy. We still need experts because very often we're faced with many variants in a person's genome in candidate genes, of which there are at least 200 candidate genes for retinal dystrophy. And so we need to have some idea of what the likelihood is of it being a specific gene, say gene A, given the clinical data that we're presented with. And to end, I'll just show 3 cases in which that probability is 1. The probability that it's a specific gene, given the presentation, is you could bet your life on it. And so we're going to have a go at this. This can only be one gene. They're all different genes, 3 different genes. 43-year-old male came to my clinic. History of poor vision since school, couldn't see the blackboard at school. And it had been relatively similar lifelong. I think the reason for him presenting to me was that he needed hyperopic spectacles for reading. He was a hyperope, and he was having presbyopia around that time. He was never able to drive. His Acute is, when I saw him, was 660. And that's his fundus appearance. And there are a few things here to notice. So autofluorescence tells us that the degeneration is only at the central retina in both eyes. The outer retina, as shown by the autofluorescent signal, is normal elsewhere. But we can see less of that in the color photographs, but the color photographs, this is a pseudo color from Optos, show us this sign here. He has a shiny retina, and that's unusual in the periphery of both eyes. It's a sort of shine we might see in a female with X-linked RP. This isn't X-linked RP, this is quite different. The OCT scan shows loss of the outer retina, and there's splitting of the retina at places at the macula. He's in his 40s. He's got an affected older brother, and his maternal grandfather was poorly sighted. So whenever we hear that term maternal uncle or maternal grandfather, we think of one specific chromosome, and that's the X chromosome. A bit further, we could get more data to make that probability even closer to 1. And he has a negative ERG. So when we flash a bright light at a dark adapted retina, the A wave is near normal. It's normal in his case, but the B wave was less than the amplitude of the A wave. And only a few things can do that. So people will, this presents in children. So this is a pediatric, male pediatric disorder. So this is X-linked retinoschisis. We don't need a whole genome scan to tell us that. We could just do a one gene test. The way laboratories are now set up is that they'll probably do a panel test to do this anyway. It's just cheaper to do the same test for everyone. But he's homozygous for a mutation in the retinoschisis gene. There's one gene that causes this disorder. This is something that's been published in India. This is rare, rarest one I've shown so far. A 73-year-old lady, not doing too badly actually, but she had an unusual retina. And she had these deposits at the macula, and those deposits on autofluorescence were hyper-autofluorescent. So unlike AMD, at least in Caucasians, AMD tends to cause hypo-autofluorescence. So this is unusual. She's also got yellow stuff right on the disc, which don't hyperfluoresce, but they are there. There are these deposits, juxtapapillary deposits. So that's unusual, not doing too much harm to her. But she's got a son who's more severely affected. The son looks like that. He's registered blind. He's lost his central vision down to 660. And a similar hyperautofluorescence, a lot of atrophy. He's more severely affected with atrophy. No, so we don't need a whole genome scan to diagnose this case or confirm the diagnosis. We don't even need a gene test. We need a one nucleotide test. There's only one nucleotide that I'm aware of that causes this. And this is dominant Drusen. And this has been published in India too. And there was a very interesting paper showing a homozygote for this in an Indian family in which this same mutation occurred, but on a different haplotypic background. So it had happened at least twice, happens in Japan as well, a different background. But we can diagnose that because we know what it is. And then finally, electrophysiology is very helpful in particular cases that are congenital and aren't degenerative. Degenerative ones show gradually reducing ERG, but those that are congenital give us hints. And this is to finish. This is a 17-year-old girl I saw in clinic, doubly unfortunate. She had PKU, phenylketonuria, a common recessive disorder. There was some delay in the diagnosis, and she had cognitive impairment, thought to be due to that. She had hearing loss, and we don't know why. But she's always had poor vision. And it's interesting that when you talk to her, she has both night blindness and day blindness. She likes to find a shady place in a room to see optimally. So she can't see in the dark, and she doesn't like bright lights, which is an unusual thing. It's not achromatopsia, it's not night blindness, it's sort of in between. Her vision was stable. She's myope. She had fine nystagmus, so she'd always had a problem, long-standing poor vision, and 660. And there wasn't much to see in her retina. The autofluorescent signal was normal. The fovea isn't as dark as we normally see it, and there is a loss of tissue at the fovea. But there's no degenerative process going on elsewhere that we can see. And this is, our electrophysiologist reported very curtly, usually gives me some numbers and things about what's going on when the patients had their test. And that's because it was a pathognomonic ERG. This lady had a higher than normal response to a bright white flash. This is a normal set of tests here. Her scotopic was down, so this is a dim light on a dark adapted eye, which only tests rods. But later, with increasing intensity, it shows up and is delayed. And there's also a delayed response to the A wave here. And then, despite the delay, the B wave is higher than normal. It's supernormal. That's the bright white flash, which tests mostly rods. The cones are down and delayed. And that's pathognomonic. That could only be one thing. We don't need a gene test for this. And this is KCNB2 retinopathy. This is a specific cone dystrophy with supernormal ERG. And electrophysiologists quite enjoy predicting genes from these cases. There are a number of conditions that can give a probability of a specific gene, given the electrophysiology, of near 1. And they're usually right. But we get the genetics back earlier now because it takes time to order the electrophysiology. So that's just a survey of some of the cases we're seeing and how genetics is helping us shape these diagnoses. Thank you.
Right. Great. Thank you so much, Andrew.
I don't want to steal other people's
series
time.
of cases. And so, Chaitra, you have a list of questions.
I think Dr. Kumar wants to ask one question. So please go ahead, unmute yourself, and you can ask a question.
So the panelists can unmute themselves and start asking their questions.
Hi, Professor Webster. So the question that I wanted to ask you is that at what point of time when you see a patient with a phenotype and a phenocopy, do you decide to do the genetic test? And in case if it is not clinically actionable, will you actually proceed with the test or not?
So we will usually proceed with it because the patient wants us to. Now, it doesn't affect the management directly because these disorders we can't treat, but it affects the advice we give people, and they want advice. They want to know as much about their disorder. They want to know whether their nephew or niece might be affected, what their future children. And to give answers to those questions, it helps greatly to have a gene in front of you and say, well, this is PRPF31. I know about this, and I can tell you about it, and it's no longer a mystery. And they also want to know where to look for treatments. Have I got RPE65 disease? It's been in the paper with Lux Turner. I already know you haven't got that, but this is proof. It's a different cause of early onset dystrophy. So you're right. It doesn't, unlike my colleagues who work in diabetes and AMD and injections and treatment, I'm not doing that much, but it's mostly the advice we give. And if we don't do the test, someone else will. And I think nowadays it's I don't know what the case is in India, but we're pretty much forced to do that. People want to know for those reasons.
Okay. Because there's a different school of thought where people don't do the test if it's not clinically actionable, but all depends on who covers the cost.
Yeah, that's the barrier we have in India, the cost factor. So as long as the cost factors are covered, I think as a clinicians definitely would like to label all the dystrophy with a gene. So rather than traditionally describing them with the names like Stargardt'S or retinitis pigmentosa and things like that. So of course, as you rightly mentioned, we have a limitation when it comes to affordability for these testings.
Yeah, I mean, don't forget though that the cost now of a panel test is comparable to an ERG, at least where we're from. Certainly an MRI scan, costs a few £100. A little bit more will get you a full panel test for retinal dystrophy. So it's comparable with the tests we order quite routinely. Whereas before, in Shomi's time, where we're having to do each gene painstakingly at a time, it would cost us a lot of money to arrive at the diagnosis, and that was more of an issue. But thankfully, prices are coming down even now.
Dr. Dipankar, you have a question?
Please unmute yourself.
Unmute yourself.
Unmute yourself, please.
Dr. Dipankar, you need to unmute yourself. Yeah.
Yeah, Professor Andrew, I want to ask one question. Is there a pattern recognition of various genes that is involved in RP? For example, RP65 or rhodopsin or any other genes. For example, there may be an autosomal dominant RP, autosomal recessive RP, or X-linked RP. Do they have a definite pattern recognition in autofluorescence. For example, if you see a sort of hyper-autofluorescence or hypo-autofluorescence, and in the, for example, you have shown some cases with the macular involvement. Okay, these are the inverse RP in the children. Whether this has a definite pattern recognition associated with a genetic locus for this.
Yes, so there are a lot of correlations of phenotype with genes. RPE65 is a good example. We can pretty much pick that up clinically. So taking a history from a person or a child's parents will tell us that the person has night blindness right from the very start of life, so congenital night blindness, and very often they're reported to look at lights. The children seek out a light, and that's quite a specific sign. Even when I talk to the adults may say, "Oh, my parents told me that I used to look at lights a lot, and I couldn't see in the dark." And then when it comes to do the fundus imaging, the RPE will still be intact. RPE65 has a relatively preserved structure despite a very poor vision. But there'll be, despite the RPE being there, there's an absence of autofluorescence. So one of the signs of RPE65 disease is a frustrated photographer who's failed to get a decent autofluorescent image from the patient despite trying quite hard. And that's a useful sign. And so that's RPE65 from the clinical features. And then there are other features. So EYS is the second most common recessive gene that Shomi discovered. And it's a difficult gene because it's a large gene. It's near the centromere. It's rearranged very often. It's hard to diagnose. Now it's easier with next generation sequencing. That has an asymmetrical appearance very often, with areas of retained retina in the northern part of the eye compared to the southern part of the eye. And that's quite, when you see that, it's quite a specific sign. So there are a few tricks. CRB1 retinopathy, which presents often in children, has a specific phenotype that we recognize. RDH12 also has loss of macula, an unusual macular appearance. And there are others, yes. Sometimes there may not be. So the splicing factors that are commonly cause dominant RP, PRPF8, PRPF31, SNR and P200, help me, PRP3, they all look similar. They're typical RP. When you've got typical RP affecting rod photoreceptors, they tend to look similar. Usher2A looks like that. It affects rod photoreceptors throughout the whole retina. And its age of onset helps you and the segregation, but yeah. But you're right. I think we should, and that's important because with these panel tests, we're shown changes in various genes, and we have to decide which is likely to be the cause of the disease because there's a lot of noise. Yeah.
Andrew, you may want to mention about PRPF31. I don't know whether you can hear me.
Yeah.
Can everyone hear me?
Yeah,
Show me. What should I mention about PRPF31?
About the symptomatic and asymptomatic.
So that's true. So PRPF31 is a common cause of dominant RP. It's the most common splicing factor that causes retinitis pigmentosa. There's a whole family of splicing factors. We don't know why the rod photoreceptors are particularly vulnerable to problems happening in the spliceosome. That's still a mystery, but they certainly are. And PRPF31 is the most common one, and it's a loss of function disorder. So the mutations that we see are heterozygous nulls. Very often they're deletions or stops, or they can be missense changes, which Shomi shown in a mouse model in a collaborative paper, kills the mouse because the mouse is not viable in the homozygous state. But that has the peculiarity of being non-penetrant in patients. So if we see a family history in which there's male-to-male transmission of a gene, but there's someone somewhere, an obligate carrier that isn't affected at all, then the most likely gene is PRPF31. We're finding other splicing factors can do it. PRPF6 can do this. That's a more recently discovered one. PRPF8 can do it less commonly. PRPF31 is more common. And sometimes you can look at these obligate carriers and they have no changes at all, and they can have a normal ERG at 70, yet have the mutation that's affected their grandchild in the early teenage years with RP. So I think that's what Chomi wanted me to emphasize, that that's another clue. That's why it's important to take a family history. There's a genetic counselor talking. And it's crucial to get a really, even if it's negative, it's helpful to know that we know who's negative, and then we can exclude things like PRPF31. So that is critical. Thanks, Shemi.
Well, yeah. One other thing, if I can have a minute or two, I'd like to mention.
I'll put me on.
I hope you can all hear me.
Yes, we can hear you.
Right. Well, first of all, I was very gratified that Andrew included me in his own age group, but actually that's not quite true. I'm a lot older than him and a generation above him. So when I first started, the critical thing was actually having large families. And Andrew may be able to show you one or two of our old family trees, which came from Alan Bird's clinic. Alan had started his clinical collection from the mid-60s, 1965 actually, when he first started his RP clinic. And painstakingly, along with Marcel J., who was our genealogist, they had put together these very large families. And the point I'm trying to make is that in those days, when I first started in 1980, in those days, we didn't have any of these rapid sequencing and gene localization methodologies. We relied on the very old southern blotting, and it was very painstaking. And at that time, you couldn't really find out, like Andrew presented today, in single cases, he's able to find the mutation, which is an enormous progress over the years. But in my time, the only way you can find the gene and ultimately the mutation was actually having these very large families, which was due to Alan Bird and Marcel J. And without their the database, the genetic database, I could not have done any of my work in those days. So Andrew may have some of these slides. It's very important to show the power of these collection of these large families. It's only because of them we were able to map and identify genes in those early days. But of course, with the technology moving on, you see now with single patients that Andrew sees in his clinic, he can actually diagnose and identify the mutation, which is a tremendous achievement. Of course, when he started doing this, I had almost retired at that point. So it's been a long time since I've retired, and there's been a huge development and progress since then. And nowadays, the ophthalmic geneticists, and particularly the retinal dystrophy clinics that people like Andrew and Purna are running, they are so lucky to properly phenotypically define as well as identify the mutation. So that is a tremendous boon now. Thanks.
Thank you. So thank you, Andrew.
It's a pleasure. Yeah, we stand on the shoulders of giants, Shemi. That's the way it is.
Yeah, I think we'll go ahead for the next talk with this good base that we had from Professor Andrews. We're just going over to Dr. Purna. He's a good friend and a colleague from Narayanethralaya, completed his post-graduation from the prestigious Armed Forces Medical College and followed by a long-term fellowship in vitreoretinal surgery from Narayanethralaya again. He's undergone additional training, as just mentioned, in inherited retinal disorders and electrophysiology from Moorfields Eye Hospital, London. And Purna will be talking to us more on the molecular and the genetic correlations for diseases prone to misdiagnosis. Over to you, Purna. You're mute. Please unmute yourself.
So I hope you can see my screen and you can hear me.
Yes, the slideshow, please.
Yeah. Yes, Purna, go ahead.
Okay, fine. So thank you so much. Thank you, Dr. Chaitra and Dr. Arka. I would like to thank our Vice Chairman who came up with this excellent idea of having advanced retina clinics. So my talk will be on some of the cases which I get for a second opinion, which are often misdiagnosed, maybe basically because of their lack of imaging facility or electrophysiology and things like that. I'll be covering few basics also because I know like there are many PGs and fellows who are logged in to watch this webinar. So let me straight away begin with a case example. So this was a 28-year-old female who presented blurred vision since 5 years and had a distance vision acuity of 6/18. So funders essentially it looked normal clinically. But when you did an autofluorescence, it did show some atrophic foveal changes and corresponding OCT confirmed there is a foveal thinning and with loss of outer retinal structures at the fovea. So this is a case of, and we did electrophysiology also, in which the scotopic responses were quite good, and photopic response were not bad, except for maybe mild reduction compared to our normative database. But she never complained of any photophobia, things like that. So basically, this is a case of Stargardt's disease. The signs can be as subtle as this. The clinically, it might look common. It had a mutation in ABCA4 gene, homozygous mutation in chromosome 1. So the Stargardt's was originally described by German ophthalmologist called Stargardt's. It's one of the common inherited juvenile macular degeneration, and variation in ABCA4 is most common cause for autosomal recessive retinal disease. It can cause Stargardt's, and it can also cause a whole variety of other retinal dystrophies also. So there are some other gene mutation which can lead to Stargardt's, maybe LV1 or CRB1, but majority of them is because of the ABCA4 mutation. So to understand some of the basics of the like how these biological membranes work, the transport of lipids across the biological membrane is critical for the structure and function of the any cells. So this is basically done by a group of ATP binding cassette transporters, which comprise a large superfamily. The human genome can encode 48 such cassette binding proteins, which are organized into 7 subfamilies, which are grouped from ABCA to ABCG. The ABCA4 is one such gene which codes for a transport gene located at the rim of rod and cones, which basically functions to regenerate rhodopsin by accelerating removal of all trans retinaldehyde. So accumulation of lipofuscin, specifically A2E bisretinoid, increases in the retinal pigment epithelium and also inner leaflet of photoreceptor outer segment and the disc membrane when there is a defective ABCA4 function. So this is the cartoon showing the final common pathway irrespective of the gene involved. This is the final common pathway where there will be excessive accumulation of lipofuscin or A2E formation, which the lysosome fails to degrade, eventually resulting in cell apoptosis. And the clinical manifestations can vary. I'll describe. See this cartoon, like if the ABCA4 is fully functional, you can still have a normal fundus. If it's partially functional, you can have a classic Stargardt's-like appearance where you'll have all those flecks. And it can also have cone rod dystrophy-like phenotype. If the ABCA4 is completely absent, you can also get a retinitis pigmentosa-like phenotype. I do get a lot of patients who are being referred as retinitis pigmentosa, but finally we end up finding a homozygous mutation in ABCA4. So the age of presentation varies between 5 years to 50 years. The vision may be good as 20/30, or it can be as worse as it can be less than 20/200. The most characteristic fundus findings are the light colored flecks, which are better highlighted when you do an autofluorescence imaging. So this autofluorescence imaging really helps. I mean, personally, I would prefer to look into autofluorescence directly than clinically looking at a color fundus photograph. That gives me a lot of clue, as Professor Webster rightly mentioned in his talk. So fovea can appear normal, as I showed in my first case, or it can have a non-specific pigment modeling at the fovea, or sometimes it can have a classic description which is used to describe Stargardt's, like wheaten bronze appearance and varying degree of yellowish white flecks, and sometimes they can also have bullseye configuration. So we don't do fluorescent angiography in Stargardt's. We don't do that. But traditionally, they say when you do these things, you do get a block or darker silent choroid. But it's not required for the diagnosis of Stargardt's unless you are suspecting an associated CNVM, which is very rare. So we don't do fluorescent angiography to diagnose Stargardt's. So OCT can have foveal thickness reduction with loss of photoreceptor, extent of which can vary. So we did try doing an OCT angiography in few Stargardt's in the milder ones. So this is the consistent pattern what we got. There's an enlarged foveal avascular zone surrounded by an area of capillary rarefaction. So this was quite consistent in all Stargardt's, but the thing I have to confess that it's quite difficult to capture OCT angiography in patients with Stargardt's, because capturing OCT angiography usually requires a good central fixation. Maybe in early disease you can do it, but otherwise it's a tough job. Need not be Stargardt's, any macular dystrophy, central vision is affected. So let me quote another case example. This was a 14-year-old female who had a blurred vision with a corrected distance visual acuity of 6/30. The fundus clinically looked normal, but autofluorescent it had subtle changes, and OCT showed foveal thinning with loss of photoreceptor layer and outer nuclear layer. So she had a compound heterozygous mutation ABCA4 as opposed to routing homozygous what we get. So mother was totally asymptomatic as per the history, but she had a homozygous mutation. Here we have a situation where daughter is heterozygous for ABCA4 and mother is homozygous but asymptomatic. So I thought let me see the mother once. I just requested if she can visit my clinic once. When I saw the mother, she was absolutely normal, 6/6 and 6 vision. But when you do an autofluorescence, she did have some early bullseye macular kind of lesion. And OCT, if you can make out in the parafoveal region, there's just a subtle disruption of ellipsoid zone. Those that subtle can be the findings in case of ABCA4 homozygous mutation. This patient, she's totally asymptomatic. Her color vision is normal, fulfilled ERG normal, maybe a mild abnormality in a multifocal ERG. So management of Stargardt's, currently there is no treatment available for this disease. You can use low vision aids, dark glasses to avoid bright light, and we need to avoid vitamin A rates supplement to reduce bisretinoid formation, because these things are known to stimulate visual cycle. For genetic counseling and testing for future treating, of course, Dr. Anu will be covering these aspects in detail in a talk now after me. So there are some visual cycle inhibitors which have been tried in Stargardt's. Basically, they act by either reducing the delivery of vitamin A, either by reducing the formation of toxic byproduct, or they may directly target toxic metabolite. So many things like isotretinoin and also vitamin A dimerization, and recently a phase 3 trial which has been on using an acucellular exemestane. So these are all basically a visual cycle inhibitors. The possible treatment in the future could be a lentiviral-based gene therapy or a stem cell therapy for the Stargardt's. We also have an ongoing research using a dual vector strategy for Stargardt's, treating Stargardt's. I think both of them are here, Dr. Arka and Dr. Shomi. Maybe they can brief about the same later. So that's my first part of my presentation. And so moving on to the second part, again, let me begin with a case example. So this was a 26-year-old male who presented with a decreased central vision, and which was noticed since 5 to 6 years, had a corrected distance visual acuity of 6/24 parts. So this is how his fundus on presentation. When I saw the foveal reflex, we could not make out, rather it was altered. So OCT did show presence of both cystoid and skytic changes. When I looked at his past medical records, he had multiple consultations elsewhere. He had undergone extensive workup to rule out posterior uveitis, including ANA profile, MANC to VDR and all that. And someone had even done anterior chamber tap to look for the viral genome in this guy. So he was started on multiple course of oral steroids in the past, and he was on immunosuppressants, the azathioprine, when he came to me. So I did an autofluorescence. So we did show some, if you can make out, some vitaliform kind of a deposits along the arcades, which are quite obvious in the right and not so in the left. So we did pedigree charting, and we came to know that he was a product of consanguineous marriage, and consanguinity and endogamy is quite very common in this part of the world where we live. So, and he said, and his brother has some problem. He has never consulted an ophthalmologist. Definitely, he has got some vision problem. So I went ahead and screened the brother. He had almost more or less similar OCT features, but these vitaliform deposits were not that very well appreciated in autofluorescence in the brother. So electrophysiological test, both the brother siblings had more or less similar, where they had rod cone dysfunction and fulfilled ERG. There's a grossly abnormal electroencephalography. You can see that there's a completely absent light rays in the bright face. So when you did the genetic testing, they had a homozygous mutation in BEST1 gene. The proband's unaffected siblings had a normal genotype, and unaffected parents were heterozygous carriers. So basically, we are dealing with an autosomal recessive dystrophinopathy. So dystrophinopathy, the Frederick Best was the one who first described the BEST1 gene in 1905. So the pathophysiology revolves around the function of the product of dystrophin gene, which is expressed on the basolateral membrane of retinal pigment epithelium. Basically, it acts its role in calcium-activated chloride channel. So the best one gene, the most commonly what we know as a retina physicians is the most common one is the autosomal dominant one. So, but you may not be aware, the best one gene can be involved in various other retinal dystrophies. And when it's recessively inherited, it causes autosomal recessive dystrophinopathy. The clinical features are slightly different when it comes to the dominant variety. So let me show a case example, the example of dominant best disease. This is how they present. Usually they will have pretty good vision with the vitaliform deposits posterior pole, which gets better highlighted when you do an autofluorescence testing. And OCT will have a typical this subretinal fluid with deposits and the elongation of photoreceptor outer segments. And when you do an electrophysiological test, classically they will have a completely normal fulfilled ERG and an abnormal EOG, which is quite characteristic of dominant best disease. So when it comes to recessive, it's quite, they described recently means maybe 12 years back in 2008. So usually it manifests in the first 2 decades of life. So autosomal recessive dystrophinopathy occurs due to total absence of null phenotype of functional dystrophin gene. And these patients are usually hyperopes and have narrow angles. It's very important to screen them for glaucoma because I have a couple of patients who lost their vision secondary to glaucoma than dystrophy itself. So whenever you diagnose a patient with ARB, it's important to screen them for a glaucoma. So clinical feature, as I described, typically they will have hyperopic refraction with subretinal hypophysin, the degree of which can differ. As I showed in my case example, it was very sparse, and it can be quite extensive, as you can see in these autofluorescence images. And when you do an OCT, there will be both intraretinal and subretinal fluid can make out as opposed to the dominant one, in which it's predominantly a subretinal fluid as far as whatever the dominant best so far whatever I've seen. So when you do an angiography, see, they have some perivascular leak. One thing you need to remember whenever you do an angiography, in case of any dystrophies, there will be some amount of perivascular leak. Please don't get confused with inflammatory ones. So when you do an electrophysiological test in the recessive variety, both ERG and EOG both will be abnormal, as opposed to the dominant, in which most of the time the fulfilled ERG will be normal. So the third case is quite interesting. This was a 21-year-old female, again born out of consanguineous marriage. She had multiple affected family members with a particular problem. So this is her fundus photos and autofluorescence. So if you see the vitaliform deposit, the hyperautofluorescent deposits, it's quite atypical. It was not fitting either into the dominant variety or into the autosomal recessive variety. So all her siblings more or less had a similar phenotype. If you see her OCT, there is a predominantly subretinal fluid, and they did had some amount of intraretinal component also. So definitely we went ahead and we did a genetic testing. To our surprise, we found a compound heterozygous Webster mutation. So mother was asymptomatic carriers. And one more surprising thing was the father was also carrying the identified mutation, what clinically was absolutely normal. I mean, when we did the electrophysiological test like lateroculogram, fulfilled ERG, it was absolutely normal, maybe a variable penetrance and expression. So we did publish this in scientific reports last year. When it comes to ARB, the autosomal recessive one, a differential diagnosis with other condition is very important, because I'm taking some time to explain this because I do get a lot of patients which are commonly misdiagnosed as posterior uveitis because of whatever the OCT appearance or the fluorescent angiography appearance. Hope all of you can hear me. I know you can't see me now.
Yeah, you're fine. Go ahead, Purna.
Yeah. I mean, there's some power issues. Yeah, it came back. So absent light rays on EOG that outweighs fulfilled ERG abnormalities, and the phenotype can vary in presentation, penetrance, and inheritance, and could be a suitable candidate for future gene therapy. So coming to the last case, I have 2 more cases. If time permits, I'll present the last one. Otherwise, I'll end with this presentation with this case. This was a 26-year-old female who was recently married, brought by husband actually. She didn't have any complaint. He thought like she's quite inattentive to the surroundings and there was no positive past or family history. So I don't have the fundus photo, and she was giving variable response based. Basically, she was not agreeing that she has some problem. Sometimes she was reading 660, sometimes she used to tell I can't see anything and things like that. The anterior and posterior segment essentially appeared normal. So I did an OCT which was absolutely normal in all cross section, both the raster scan and the star scan. I could not make out any disruption in any of the layers. So autofluorescence was also normal. So we thought maybe she's malingering. But before we label any patient as malingering, we need to do a electrophysiological test. That's what I did. And I was in for a surprise in this case. Our photophic responses are completely absent. I mean, there was light adapted responses are almost like unrecordable. So basically, this is a case of achromatopsia, which is a stationary cone dystrophy. So, but this is the first time I have seen someone with absolutely normal OCT with achromatopsia. Because usually, achromatopsia patients, whatever I have seen, usually they'll have these subfoveal cavitations like this. And this patient, I could not make out any abnormality. Our OCT was absolutely normal. So this, if not for ERG, definitely would have labeled this as malingering. So Dr. Arka, do I have 2 minutes of time for last case?
Sure, a minute.
A minute. Okay, fine. I'll just try to finish it in a minute. Okay. So this case, I did share this case with Professor Webster also. This was a 14-year-old Asian male who presented with diminution of vision for distance and near right eye following an episode of fever. So there was no history of trauma, night vision problem, negative family history, and clinical examination. Detailed UVA workup was also inconclusive. So its best corrected visual acuity was 660 N36 and 66 and 6 in the left eye, and color vision was grossly abnormal in the right eye. So fundus left eye was completely normal on clinical examination. Right eye did had foveal atrophic changes with the early bullseye maculopathy configuration. So OCT showed foveal thinning with loss of photoreceptors in the foveal region and also outer nuclear layer. Left eye was quite okay. This was his fundus autofluorescence. You can make out the changes. The asymmetry was more obvious when you did a multicolor imaging, which is available with the Spectralis OCT. So, but again, when I did a full-field ERG, in the right eye, the light adapted, left eye was absolutely normal. The right eye light adapted response was absent. It was kind of an unilateral achromatopsia-like picture. Okay, I don't have an explanation for this. We did screen all the family members. We collected the blood. We subjected them for the whole exome sequencing. We did end up getting all these genes. I think Dr. Arka, you also might remember this case. So, but nothing was inconclusive. The closest one was CRX, but it was present in father also, was absolutely normal. So the patient was followed up for 1 year. The clinical status and the ERG remained the same. So we are just following him up. The vision, everything is stable so far. To conclude, I would like to say better understanding of the disease based on genotype and molecular basis for phenotype has become primary importance. It helps patients and the clinician to make better choices, better understand the prognosis, and also to know what future holds for them. So thank you.
Thank you, Purna. We'll be having questions for Purna and Anu after Dr. Anupita's talk. Anu, if you can unmute yourself and share your screen, please.
Yes.
It gives me great pleasure to introduce Dr. Anupita Ghosh. She's a scientist and a genetic counselor for Narayana Nethralaya. She did a PhD on mechanisms of cell cycle regulation from the University of Missouri in Columbia. Her current research focus is on molecular mechanisms of retinal dystrophies. She takes care of academic training in the lab and runs a Gen I clinic. She therefore trains not only just PhD students, but also helps both clinicians and patients understand the genetic reports, which is a major boon to all of us. Thank you for being part of this meeting, Anu, and over to you.
Thank you, Dr. Chaitra. Is my presentation visible?
Not yet. You'll have to click on the share screen below.
Okay. I thought I did that.
Have you opened your presentation?
I did. Just a second.
Yeah.
Let me try that again. Is it visible now?
Yeah. It's just coming up now. Slideshow, please.
Yeah.
Yeah. You're good to go now.
All right. All right. Good evening, everyone from Bangalore. And today I'll be talking about the genetic counseling that we do for retinal dystrophy patients and families through the clinic called Gen I here at Narayana Nethralaya in Bangalore. So thank you, Professor Webster and Dr. Purnachandra for the introduction and, for all that background information. It's going to help me also. So I want to say here with the help of this slide is that with the advances in medical genetics, research technologies, and of course, all the bioethics involved in this, genetic counseling has indeed become an important integral part of healthcare. And when it comes to these facts that I'm talking about, the first one being the genetic and phenotypic overlap or heterogeneity. And that is what is seen on this slide. And that makes genetic testing very important. So finding the gene mutation specific for that phenotype, and of course documenting it, and which is going to help eventually in the confirmation of the diagnosis, and of course the better management options. The second point is that, as you can see on this second slide, that the number of people with visual disabilities and who are blind
Anuprita, you're not coming through. We can't hear you.
is quite significant. And there are consequences of visual impairment. Like, oh, okay. Is it because of the internet connection?
Yes, it's possible because there is a lag. It looks like it's because of your internet connection.
You can turn off your
video.
Hello.
Turn off your video. We'll get a little more bandwidth then.
Hello?
Yeah. If you can turn off your video, Anuprita, it'll be easier. We might be able to get better audio reception.
Now it's okay?
There's still some lag.
I did that. Can you hear me now?
Yeah. Yes. Yeah, much better.
Okay. Okay, fine. So as I was saying that visual disability is indeed a big challenge. So even though the first question that they ask us in the Retinal clinic is there any therapy available right away? And unfortunately the answer is no, but emotional support is the need of the hour. The third point, which is really important, is that the window. So I want to say that with the help of this slide here, the arrow in the center is showing the disease progression, and this first window where there are still some photoreceptors left, and it would be ideal if patients and their families come in this window, for the clinical diagnosis, for the genetic counseling, and of course they should also opt for genetic testing. And because it's going to be a point that gets discussed in genetic counseling, and of course as the disease is going to progress, it's going to be more depressing for the patients, and that's where the emotional and psychosocial care becomes very important. All right, so this is the workflow at NN. The patients first come to the clinic. The clinician or the retina specialist is the one who first sees and does the diagnosis of IRD, and then they get referred to the GenI clinic. The coordinators of the GenI clinic start by making an elaborate pedigree or family history, and they also share this handout. And this handout is very important because the day when they hear the diagnosis, it can be extremely, devastating for them, and it's like a pander of emotions that gets open, and it's very hard for them to understand what needs first priority, and they can really go numb. So this gives them a breather. This handout is something that when they are more receptive, they can read about what to expect in genetic counseling, and then when they are ready, they can then schedule for the appointment. So GenI clinic is not just going to any other clinic, but I have mentioned here the elements of GenI clinic or genetic counseling in the bracket here, which are education, information,
Anuprita, we can't hear you. Hello? Anuprita, can you hear us?
She's lost connection, is it?
Yeah, because I can't hear back from her at all. Yeah, I think she has because she's logged off. So why don't we take some questions if Dr. Poorna can come back online as well, and if Professor Webster's here. There are a couple of questions till Anuprita joins us back. So one of the questions we have is how do you differentiate between cone dystrophy and Stargardt's? Because often the clinical picture and OCT may have similar findings in the early stages. So Purna, would you like to take that, or Professor Webster, would you like to take that?
I'm happy to talk to that.
Yes.
So we use electrophysiology, really, both Purna and we would see whether or not the full field ERGs are normal, in which case we'd call it type 1 Stargardt disease. We tend to use the term ABCA4 retinopathy now because it's so varied and it includes Stargardt disease. Many people that have Stargardt disease as children don't look like it later. So we call it ABCA4 retinopathy increasingly. But ERG will answer the distinction between whether the cones are affected or whether it's just affecting the macula. And it's useful because very often in the latter cases, it remains stable, and that's useful information for people. And also we can tell from the genotypes, some genotypes can predict the type 1 macula-only disorder. And other genotypes, like the one Purna presented, he presented a null genotype, a stop. That's not macula only. That will give rise to a cone and a cone rod dystrophy and continue to progress.
Right. I guess that kind of answers the next question. Is the different stages of progression a cause for the misdiagnosis? So that was the next question.
So yes, it can confuse things. So ABCA4 can look very different at different ages. So we have to have a broad appreciation of what it can do. But the history is very important. So Purna mentioned RP, and when you talk to people with severe ABCA4, they're adults, they've got bone spicules in their retina. When you talk to them, they will have lost their central vision first. They'll tell you that. It's not RP, actually, because their symptoms are incompatible with RP. It's not a rod photoreceptor problem. It's a central retinal and cone problem that they will describe to you. So although it's called RP, I get a little uncomfortable with that because it isn't really. I have never seen anyone with ABCA4 and proper RP, rod photoreceptor disease. All of the many hundreds of people I've seen have had cone first disease, either affecting the macula or later on their whole retina.
No, we do have like patients with ABCA4 mutation with atrophic maculopathy and this bone spicle-like pigmentation in the mid-periphery. So, and to answer, continue with that question, the similar thing, guys, I totally agree with the Professor Webster. The final is the genetic testing, which can clearly delineate between a cone dystrophy and a Stargardt's. So sometimes clinically, in case if you don't have facility, of course, which is the case in most of the places in India, you can definitely go for sometimes imaging. If you see a lot of flex or hyperfluorescence flex, I'll be more in favor of diagnosing a Stargardt's. So, and cone dystrophy, again, there are two types, the stationary and the progressive one. The stationary one, like achromatopsia, are like self-explanatory. Like the moment the patient walks into the clinic, you'll get to know, like they will have a lot of photophobia, and they will have like near normal looking fundus with, when you do an OCT, they can have a foveal cavitation and things like that. But of course, in a cone dystrophy, like we see the Stargardt's is also, if I ask me, it's also a cone rod dystrophy. Like it starts with the cone photoreceptor degeneration. But pure cone dystrophy, you want to differentiate, the ultimate thing we need to do is you can do a genetic testing.
Great. So I think Dr. Deepankar wants to have a word. You'll have to unmute yourself first, please. Please unmute yourself, Dr. Deepankar. We can't hear you. Yes.
Yeah, can you hear me now?
Yes,
yeah,
yes.
For Stargardt, no, it is basically a lipofuscin expression. For cone dystrophy and RP, we don't see a lipofuscin expression there too much. Now you see the mutation for ABCA4, basically a transport protein. Is it there is a mutational site difference between a Stargardt's than that of a cone dystrophy or RP changes, or what you call, is there a ABCA4 dystrophy expression is also there in adult flebimaculatus?
Okay, thank you. I think we can carry on with Anuprita's talk. Please share your screen and unmute yourself, please.
Can you hear me?
Yes, please.
And you can see my slide as well, right?
Yes, we can.
Okay, sorry about that. It's the Bangalore weather. We have a storm outside. So before I disappear again, as I was saying that in the genetic counseling, which has two parts. So in the pretest counseling, we start by educating them about the disorder and the genetics, including the Mendelian inheritance. And we do help them understand their own family history, the pedigree, and also the medical history. We counsel them to promote informed choices and, for their emotional well-being, for career testing, for family planning, or even prenatal testing, which is of course done with a gynecologist on board. And we do talk about the advantages of genetic testing as well as limitations. But as you can see, it's not just about genetic testing. Now, if the patient or the family members want to opt for genetic testing, then we collect 3 ml blood sample of the affected person, the proband, and the two related members like parents in a EDTA tube, and with proper forms signed, we send it to Medgenome. That is the company that does the genetic testing for us. It takes some 4 to 6 weeks for the reports to come. Once we get the report, we schedule the post-test counseling. And in the post-test counseling, if the report is conclusive, then we help the patient and the family members understand the report. And we talk about the gene mutation and the science progress on that, including the therapy, progress. We also share this report with the clinicians. And if we need to go back and forth with them, then we do that for the clinical and genetic correlation of it. Sometimes the reports are not conclusive or reported as VUS or variant of unknown significance, and we see that 40% of the times. And so these reports, we sort of mark them and we revisit them with Medgenome for a reanalysis. Now, this genetic counseling, there is no time limit on that. It can be 1 to 2 hours, and it's to provide the patient and the family members a non-judgmental environment and a safe, confidential one too, where they can talk about anything, any questions. And we do encourage them to do that, to ask as many questions. We do encourage them to meet other family members if they are willing to, who are either have the same dystrophy or the same gene mutation, but it is entirely up to the patients whether they want to opt for that or not. And it's an open dialogue. They keep in touch with us. This is not just a one-time visit. All these years, even I continue to meet my patients who have met maybe 4 or 5 years ago also. So all these years, my patients have been my teachers, and it continues. The GenAI clinic continues to evolve. Okay, now I'm not able to change my PPT slide. Okay. Yeah. All right. So this is a pedigree of one of our patients, and as you can see, it is a 4-generation pedigree. The third member of the third generation is affected. When he came to us, he was 30 years old, and he was quite distraught, upset, depressed, and he's the only one affected in his entire family. His older brother and sister are fine. His parents, they are related to each other. And when he came to us, there was a lot going for him. I mean, his vision has deteriorated quite a lot. He was in the midst of changing his job. He had stopped driving, and he was really unsure of his future. But then he did agree to go ahead with the genetic testing. Once we received his report, we met again for the post-test counseling, and Medgenome reported a pathogenic homozygous mutation in the gene called PDE6A. And because he was counseled in the pre-test, he did go ahead and educate his parents about the genetic validation that also needs to be done at this point. And he didn't stop there. He also educated his older brother and sister about the carrier testing. And eventually they all agreed to undergo testing, and they all are heterozygous carriers of the same gene mutation. And of course, they also discussed amongst their family and in their community about, how marriages within the same family should be avoided. Through the GenAI clinic, because we also maintain our patient database, what you are seeing now on this slide is the integration of the genetic and phenotypic data. So these are OCT images of 3 different patients. The first two patients, they both have LCA, and one is because of a mutation in AIPL1 gene and the other one in GUCY2D. As you can see, the AIPL1 is far more severe than the GUCY2D one. And then the third patient is the one just now I spoke about, the one with PDE6A mutation and retinitis pigmentosa. And his is definitely, much better than the LCA patients. And interestingly, all these three genes are involved in phototransduction. This is another example of our patient database that we maintain. And this is very, very important with respect to the clinics, also the genetics. So I don't know whether I have enough time now, but I'll just pick up a couple of cases. The take home from this slide, I want it to be that, say for example, the first case, it's a query for whether it is LCA. So children, when they are still growing and the disease is still evolving, we do get these queries from the clinics. And if these families opt for genetic testing, like in this case they did, there was a pathogenic homozygous mutation reported in a gene called GUCY2D, which is already known in literature to cause LCA. So this confirms the clinical diagnosis. Then, the second case of whether it is RP or choroideremia, again, the CHM gene mutation confirmed, but it didn't stop here. The Genai clinic helped them also with the carrier testing for the daughter, and she is also a heterozygous carrier of that. The other thing, the take home is, if you look at the case 5 and 6, so the clinical diagnosis was Stargardt's, but the mutation that was picked up was in a gene called CERKL, and the mutation is a deletion mutation. It is quite a detrimental one, homozygous, and it is known to cause retinitis pigmentosa. So a very tricky case, and this definitely, again, needs to emphasize for the patient also the need of regular follow-ups with the clinician for the clinical correlation. And of course, the documentation of all those minute changes along with it. Then sometimes we get, I mentioned earlier, VUS, as in the report, which is variant of unknown significance. Now, these cases, of course, a regular follow-up with the clinician, but we need to revisit these cases for a genetic reanalysis. So that's something that we also do through our clinic. All the patients that come to Genai clinic, we also get to see the prevalence of IRDs and also the distribution of gene mutations in our patients. So as you can see here, we have seen 66% of all the patients, 66% are the ones with retinitis pigmentosa. 71% have autosomal recessive mutation. And this is the gene distribution mutations in these patients. Last, I want to say that it is a teamwork of scientists, genetic counselors, and the clinicians for patient care and hopefully eventually personalized therapy. So thank you to GrowLab and my Genai team, my mentors, and of course, my clinicians team. And I would like to end with this quote by Helen Keller, I think, which is appropriate given the current situation. All the world is full of suffering. It is also full of overcoming it. Thank you.
Thank you, Anuprita. That was beautifully put, and I liked your conclusion as well. I think Arko will take over now. We will be starting the next segment. Over to you, Arko.
Right. So in our next segment, we have our keynote speaker, Professor Debashish Sinha. Debashish is there.
I can't share the screen yet. Can you hear me?
Yes, we can hear you. So Dr. Debashish Sinha is the Jennifer Salviti Davis Chair of Ophthalmology Research at the University of Pittsburgh School of Medicine. He is also an adjunct faculty at Johns Hopkins University School of Medicine, where he was previously, and he has a long list of awards and accomplishments that that anybody would look up. Now, what he has done incredibly over the several years is work out a variety of different cellular mechanisms that drive retinal diseases, from diabetic retinopathy to AMD. In fact, in AMD is contributions are well noted throughout the world. And today he's going to talk to us about something that is less talked about in retina. And thank you, Dr. Sinha, for accepting that invitation, because this particular case, very few people talk about because it's very rare, but I think it's very relevant for us, especially the students and young clinicians listening to these talks to understand the molecular basis of it. So over to you, Devashishda.
Okay, thank you very much. I'm trying to share my screen. Can you see my screen?
Not yet.
There you go.
Anuprita, are you still there?
Is it okay now? Can you see?
Yes. Yes, we
Okay.
can.
Okay. Thank you very much. Good evening to my friends and colleagues in Bangalore. I really miss, if COVID-19 has done anything bad, it has stopped my trips to Bangalore, and I really miss that. And it's always an honor to speak at Narayana Nathralaya events, and particularly thanks to Director Ghosh for inviting me. So as your webinar said, that the theme being science, clinic, and care, I'm going to divide my talks into three different parts. The science part, I will talk about the cell type astrocytes, is a glial cell, and also talk a little bit about the fetal vasculature of the eye that will lead to the disease, which, I'm not a clinician, will be very short, a few slides to talk about a disease called persistent fetal vasculature. And then we are, as Orko mentioned, we try to see that if we can develop any therapy for the mechanisms that we study. And so that's when I will end. So it's very important, that how much, and it's amazing that science has come to now, and we have talked already about the genetics and how much we know. But still, if you look back, and here I'm showing the work of Santiago Ramon y Cajal, who is a Spanish scientist, and his work in early 1900s, so about 100 years back, is still today recognized and is based on what he has done on a particular cell type, the astrocytes, which is the glial cells, which is mostly in the brain and also in the eye. Although it was the astrocytes, I must clear that was found by a German scientist, Rudolf Virchow. But now, as Andrew has also alluded to, that how heterogeneity in genetics plays an important role in diseases. So we now know that even cell type heterogeneity plays a very important role in diseases. So again, back in 1906, when Santiago got his Nobel Prize with Golgi, who found the Golgi apparatus that we talk about, showed that there are actually 4 different types of astrocytes: fibrous, protoplasmic, twin, and again fibrous. And these 2 fibrous differs because you can see, and this is nearby observations by just morphology, because he was a very good histologist. So with many things that he had, he was also a very good artist. And what he used to do is to look at slides and then try to figure out what the disease did. So now that we know a lot about astrocytes, inflammation, how the cytokines and the chemokines, on the right side of the slide, you can see that how in paralysis he found that that he called at that time giant astrocytes, which we now know as activated astrocytes, and how these activation do lead to inflammation. So it is also very interesting cell biology with the retina. I think the retina is not just only the window to the brain, but retina is something that teaches us about cell biology that many other fields do gain from retinal cell biology. So this slide shows the work from Dr. Connie Sepko at Harvard and many others that followed her, where they wanted to see about the development of mostly retinal cells. And if you see in this cartoon that retinal ganglion cells are born at around embryonic day 11, and these are all mouse studies, and up to postnatal day 2, they differentiate and then they become mature. So you can see retinal neurons, RGCs, amacrines, horizontal cells, bipolar cells being born and differentiating at different stages, right? So are the photoreceptor cells, cones and rods, and also one of the other glial cells that I'm sure you all are familiar with, molar glia. But one of the interesting things is that the astrocytes are not actually the retinal cells. They immigrate into the, they migrate into the retina from the brain to the optic nerve. And like it's not only the human nature, even cells do play an important role, and it's always there with immigration, and migrations are problematic. So they only survive mostly in the nerve fiber layer. So most of our studies, because we try to understand molecular mechanisms of certain cell types and then try to link it to diseases, we start with animal models. So we generally look into genetic models. And today, for today's talk, I will depend on this rat model that is a spontaneous mutation on a crystalline gene. And just for phenotypically, so this is the wild type where you can see the normal eye. Then you can see in the middle, these are heterozygotes which have nuclear cataract. And that's why we call it Nucleolus, because that's where initially we got these rats. And then through breeding strategies, we got the homozygotes which have microphthalmia, as you can see here. So this gene we identified, the mutation we identified about now more than a decade back, and it was really a pain at that time. And Dr. Bhattacharya can allude to that also, that as he said, that at that time, genetics tools were not readily available, and the rat genome was actually, was really in a bad shape. But anyways, with help with others, we identified the mutation in the CRYBA1 gene that is a crystalline that encodes for beta A3A1 crystalline. So crystallines, as most of you know, are the major structural proteins of the lens. But very recently it has been shown that they do provide functions in different cell types, and during evolution it was recruited in the eye. So this mutation is a 27 base pair insertion in exon 6 of this gene, and in the gel here you can see it's just 27 base pair changes. And although we have not looked back and studied more, but it has more or less an Huntington type of insertion. So tat, 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 lot of repeats, but not going to get into that today. So since we identified the crystalline at the retina showed a lot of abnormalities, although it's a lens-specific gene that interested us, and we wanted to see in the neuronal retina, where is it expressed? And for that, we actually did a technique which is known as laser capture dissection. So we took the retina from these are from wild type rats, and we dissected different areas of the retina. So like the nerve fiber layer, the photoreceptor layer, and also the inner nuclear layer, and then tried to see that if crystalline is expressed in any of these layers. Means I'm not going to go for today's talk. We know that it is also expressed in the RP layer, but here it shows that it is mostly expressed in the nerve fiber layer. As you can see, by 24 days, there is some expression by 4 months, but by 10 months, the expression is more or less gone. And this shows that, what I'm telling you, that it is nerve fiber layer. We took Taiwan and GFAP as markers. So phosphodiesin for photoreceptors and Chexten for the inner nuclear layer. So further, what we did is we looked into both ganglion cells and astrocytes. I'm only showing you astrocytes because there is very faint expression of this protein in the astrocytes, but is in the ganglion cells, but is highly expressed in the astrocytes. In the astrocytes, as you see here, expressed by GFAP, and this is the crystalline. So it's highly expressed there, and so we see the expression is in the Nuke1 also. So the Nuke1 mutation, it's a loss of function, or it can be a gain of toxic function, but the protein itself is still there. So, and to prove that this gene does express in the astrocytes in somehow involved in the structure function of astrocytes, we did some retinal flat mounts as shown here. So these are 6-day wild type, and on the right hand is the Nuke1 homozygous, and then below you see the 10-week. And astrocytes are known to have a honeycomb type of structure like this because it's not required in humans, but in rodents, astrocytes are very much necessary to form blood vessels. And in many mammalian species, astrocytes actually determine the blood vascular structure. In humans, it's only enwraps the blood vessels for sure, but it's not required really to guide blood vessels. But you can appreciate here that both in 6 days and by 10 weeks, it is actually it is very abnormal. They actually try to ensheath each other, and it's the honeycomb structure that you see in wild type is completely lost. We don't know yet what happens because we don't see the Nuke1 astrocytes do survive abnormally. In fact, they are, and we have showed previously that it inhibits anoikis mediated cell death. It is a but the nucleus looks amazingly abnormal. So you can see that they have clefts, and the nucleolus is larger in size compared to wild type ones, and it's always in one and also located in the periphery. So is the nuclear function somehow the protein regulates? We have some knowledge now, but for the sake of time, I'm not going to go into any detail. So with that, that was about astrocytes that I had to tell you, and I'm moving to a little bit about the fetal vasculature or the hyaloid vasculature, and I don't have to tell this crowd what it is. I'm sure you all know the eye has a very unique vasculature system, right? So during development, the lens particularly and the whole eye is fed by what is called the fetal or the hyaloid vasculature, and you can see the pupillary membrane tunica vascular lentis and the vasa hyaloidea propria. But what happens is that when the development is complete, these vessels regress. And this is important because you don't want to be born with blood vessels in front of your eye or the back of the eye, so that the lens could not focus light into the retina. So this involution starts around day 7 or 8 in rodents, and it completes by eye opening, which is about in rats about 3 weeks, similar in mouse. But in humans, the regression happens, before birth, because when you are born, the blood, this fetal vasculature is gone. So with many different types of abnormalities shown in this model, one of the things that we found out was that, and this is taking the rat optic nerve at postnatal day 10, when involution has already started, the blood vessels are regressing. So in the top panel, A, B, C are all wild types. So we are staining with 2 different markers for the astrocytes, because it seems that there were some cells around it. And this is for aquaporin 4 and GFAP, 2 markers that we used for astrocytes. And the bottom panel is the model, the Nuke1. We see that at P10, when there is normal regression started in the wild type rats, there it's still the hyaloid artery is much bigger here in the Nuke1, and we can see that actually they are covered by astrocytes. So this was very interesting to us, and then we looked at at P20. So I told you this is just before birth or around birth, that you can see again in the top panel where you can see the wild type cells, rats, where the hyalid artery is regressing, more or less regressed, and there the astrocytes are more in the nerve fiber layer. But you can see here in the model that the hyalid artery has not regressed, so regression did not occur, and they are ensheathed by the astrocytes. And further, we did electron microscopy to be very sure that there is nothing else happening. And you can see this is wild type at P3 when the hyalid artery and the and the fetal vasculature is intact. So you can see the lumen, and this is the posterior capsule of the lens. And again, by P14 of wild type, you can see that the regression has started. It starts degenerating. But interestingly, at P29, when it should have regressed completely, you can still see that it is intact by EM also, that you can see the nucleus, you can see some RBCs, so the fetal vasculature still remains. So we also try to look at the blood vessels by staining with isolectin B4 to see, to be very clear that it is not remnants of something else that has not cleared off. Again, in wild type, you can see that by 20, there is no hyalid artery that you can see here, more or less. But you can see that in the Nucleolus rats, the hyalid artery has not regressed, and it is ensheathed by the astrocytes. Right. And one of the things that is known, so very little is known about this regression. It's a very interesting model, but somehow there is not much interest in the research or the disease of this eye disease for some reason, which we do not understand, because I don't know if hardly any labs work on it. So one of the labs that has started working, that had started working before we did, was Richard Lang's laboratory at Cincinnati, a very famous developmental biologist, because there are many things that is very interesting. So because this regression happens, if you even time it, it's very difficult to know. And it is interesting that by eye opening in rats and mice, you would not see any remnants of anything. It is cleared so nicely. So he had shown that actually there is a timing during the involution where the pericytes send some signals, and these are macrophages that are stained here with ED1. So the macrophages come into the vitreous, cleans it off, and just goes away. So it's very, very, very interesting. In our case, in the Nuke-1 model, you can see again that the hyalid artery has not regressed, and you can also see that there are, so somehow the signaling to bring macrophages into the vitreous is still there. But is it a physical barrier, the astrocytes, that somehow it cannot regress? We do not know about that. But this is the interesting part that we think we would like to understand. So as I said, we very much depend on animal models. We were trying to see that if it is this crystalline which is doing, or it is something else that is happening that has this retention of the hyalid artery. And although I showed astrocytes in our model only, even if it's not shown, that people are now saying it, there are several animal models, because it's very, sometimes, somehow, little bit, I would not want to use the word common, but it shows retention of the hyalid artery in many of the other genetic models. And invariably, there are astrocytes ensheathing these vessels. So we made some transgenic mice where you use the human GFP promoter, and we took the rat Nuke-1 cDNA, the mutation, and tried to overexpress them in the astrocyte and see what happens. We also did the wild type as the control, but again, I cannot go into detail. This gene is very interesting. Nature does not allow it to overexpress this protein into astrocytes. But interestingly, again, in this transgenic mice, we find that this is in 3 weeks. And flat mounts, you can see again very well structured honeycomb-like astrocytes. But again, there is abnormality in this mice where we are overexpressing the crystalline only in astrocytes. And again, we see that there is, so by 3 weeks, it has regressed in the wild type mice, but again, there is hyaloid artery that is not, and they are enshielded by the astrocytes. So this is interesting. And then we went recently a stage further where we wanted to study a little bit more, because CRYBA1, the gene which is mutated, is very interesting. It is one of the very rare eukaryotic genes that uses a viral mechanism to make two different proteins called leaky ribosomal scanning. Many of you have heard about moonlighting proteins, and we think about mutations at different regions, different proteins. And there are many cases, some of these cases where it uses these two proteins to localize in different parts of the cell, and then they function differently and everything. So one of the interesting things we found out, and we made mice using the CRISPR-Cas9 technology, where, so these are the two start sites, ATG, where it makes beta A3 and beta A1. So we completely knocked out. So we knocked down beta A1 because it is just 17 amino acids. It's very a big problem to actually knock out completely A1. So we just strengthened the Kozak sequence, and so that it has to make an A3 and makes only A1, but the Kozak sequence is not strong enough to completely knock out beta A1. But we did knock out completely beta A3, where we inserted and just inserted two G's with the T's, so that we can actually knock out beta A1 completely. Interestingly, what we see is that in wild type, again, by 6 months, everything is regressed. I'm not showing you beta A3 knockout, because in the knockout also there is nothing. But beta A1 knockdown, again, there is persistent of the fetal vasculature. And again, we'll not go into further detail, but it is true that we have found that beta A1 crystalline plays a very important role in the astrocytes in the retina, but maybe not beta A3 protein. One of the things that we do not understand is that in the retina, so on the left part, this is from the wild type rats. You can see the red is astrocytes, the green is blood vessels. And we know that it enwraps the blood vessels. That is one of the important functions of astrocytes. Leakiness happens if the astrocytes enfit, do not ensheath properly. We do not see that in the retina of these other, in the Nuke rats, right? They do not seem to ensheath, and we know that they have leaky vessels. So we do not know that is the astrocytes going into the vitreous and ensheathing them, does it take some or get some functional proteins, or do they change themselves? Because here they are not ensheathing the blood vessels in the retina, but they do in the PFV. So this is the question that we have not addressed. So with that, I am moving into this disease that happens. So if so the Nuke or the mice that I've showed becomes a very interesting model for a disease that is known as persistent fetal vasculature disease. Many of you might know it as PHPV, persistent hyperplastic primary vitreous, and this was changed into PFV by Dr. Maud Goldberg, who was my chair when I was at Johns Hopkins. And Dr. Goldberg said that because mentioned and renamed it because the severity differed and the completeness of the vasculature would be better to name it as persistent fetal vasculature. So there is a severe form, which I told you maybe previously in the cartoon, where the entire vasculature, fetal vasculature does not regress. Then there is a moderate form where the hyaloid artery and some of the tunica vascularis lentis you can see. And there is a mild form where it is mostly the hyaloid artery. So in our case, the Nuke is the severe form, and the mouse models for some reason shows moderate to mild form. So in humans also, then we wanted to show, and see if there was this vitreous enshielding the artery. And we are very fortunate because when I was at Hopkins, Dick Green was the pathologist, and he had sections of anything or any in retinal diseases that you could look for. And he kindly provided this one to us, at least 6 of them, I think. And we did see when we section it some, fibrous-like material that enshielded the hyoid artery. And then we again stained it for aquamarine 4 and GFAP, and also the retina and the hyoid artery. And we see that, yes, definitely there is astrocytes enshielding that. So that leads to, then we came to know that if this is the crystalline, that the model that we can look at, and there are other models, as I mentioned. So these astrocytes that ensheathe the vessels might not be only because of the crystalline, but this crystalline is mainly a lysosomal luminal protein in astrocytes. So it does bind to VATPase. And so we are thinking that if there is a lysosomal abnormality in it, then could it be something that we can find a cure for it? And what we did is that we looked into proteins that interact with beta-A31 crystalline. And one of the proteins that was of interest to us that it bound to was EGFR. And EGFR, as you know, plays a very important role in endocytosis in many of these cells. So nutritional health and everything of the cell depends on the endocytosis, clathrin-mediated endocytosis of EGFR. And EGFR can also have a non-mediated clathrin endocytosis. So this is just confirming, and by co-immunoprecipitation, that yes, and the crystalline does bind to EGFR. What we also found that in Nucleolus rats, the expression of EGFR was significantly higher than the wild-type rats. So to prove that it is true that it is the crystalline that is making the EGFR expression higher, we overexpressed both in the wild-type and the Nucleolus cells and the crystalline with using the pcDNA vector. You see in the wild type, nothing happens, but definitely in the Nucleolus, you can lower the expression to more or less to the wild type level as shown here in the graph, meaning that in this Nucleolus astrocytes, EGFR expression is higher only because of the loss of crystalline, which is required for its function. So I know this is a very busy slide, so you have to more or less believe me what I say. But as I told you that this is a lysosomal luminal protein, and EGFR endocytosis lysosomes plays a very important role because the recycling happens in the Golgi to the lysosomal compartments. So we did a electron EM that is shown in A. In the wild type, you can see these are all lysosomes. And in the Nucleolus, you can see that they have black dots inside the lysosomes. And this is, we stained with AGFR. So it is immunoelectron microscopy, and you can see that it is there. So, does the lysosome play an important role? Because our theory was that if this is placed in crystalline mutation that is doing the hyoid fetal vasculature regression, inhibits fetal vasculature regression, but can it be that if there is an abnormality in EGFR pathway or in lysosomes that this can happen? And that is true because we looked at EGFR. So again, you see we treated them with chloroquine, which is a lysosomal inhibitor, and EGF, which will activate EGFR. It will activate, then internalize, and then degrade. So in the wild type, if you take, if we treat with EGF for about 1 hour, you can see that within an hour, our EGFR goes down. So it has already gone, and because the lysosomal function is okay, it degrades. But if you block the lysosomes by treating with CHQ and even treat with EGF, you can see it still accumulates. So meaning that yes, lysosome itself can be a problem. And as I said, in Nucleolus, lysosome is a problem. So even if you treat with EGF, there is nothing much. When the lysosomes are functional, nothing much can be done because it has abnormal lysosomes already there. So this is also showing and that it will affect the mTORC1 pathway because that is downstream of EGF. And the last one here down below, you can see that how EGFR is degraded in 1 hour time, but not in the Nuke1. So meaning more that there is a lysosomal impairment in the Nuke1 that this is happening, and any other gene that is affecting this persistence of the fetal vasculature may be EGFR might be target. So what I showed you, told you that these astrocytes abnormally initiate the hyalid artery, so it goes and migrates into the vitreous and covers it. So EGFR, we used an EGFR inhibitor that is available, gefitinib, and gefitinib, if we do the migration and does go down in vitro. What I was more wanted to show you all that, okay, the proliferation is up to a factor, the proliferation is gone. So, but does it have a toxic effect? Is it that that the astrocytes, you are just killing it like by causing cell death? So what I show here in this is that if we look into by Ki67, a proliferation marker, you can see that gefitinib treatment, actually now you can see that the proliferation goes down. So, but when you use CC3, which is a apoptotic marker, you do not see any difference. So it does directly affect proliferation, and I told you migration also. Again, we also tried with using PCNA for proliferation marker, and you can see that in PCNA also it goes down, but there is no effect in PARP if you try with gefitinib. So having apoptosis is not affecting. Finally, we did a live dead viability assay and see that the gefitinib has no effect on the cell death of the astrocytes. So it is mainly affecting proliferation and migration that we want to look into. And we tried in our rats, and we injected gefitinib from P10 to P29 and then sacrificed them at P31. And this is wild type, these are retinal flat mounts, and you can see this is blood vessel marker collagen 4A1, GFAP for astrocytes. And you can see that by that time, the hyalid artery has more or less regressed in the wild type rats. In Nuke1, you can see that it's still there at that time because it fails to the normal regression. But when you treat it with gefitinib, it does again start regression because the astrocytes cannot reach the vitreous and the hyalid artery. It's not 100% proof because these are the sections that we have tried to measure how much of regression happens. And we see that it is about 30 to 40% regression. So we now are trying to see if you can do something with gefitinib and try some other lysosomal or autophagy inhibitors and see that if we can get a better way for, but this could be for a severe disease, maybe it is much difficult to cure, but for moderate and mild, maybe it is better. We have not looked into our mice models yet, which we are now planning to do. So in summary, what I told you today was that in the disease persistent fetal vasculature, we believe astrocytes play an important role because the astrocytes are mostly confined in the nerve fiber layer. So in the normal situation, the macrophage goes in and just clears of the blood vessels, and it's a normal regression that occurs. In a model like Nucleolus or also in the diseases, you can see we believe that, or we hypothesize that the astrocytes enshades the hyalid artery. It could be a physical barrier, or what it is, we don't know, because we do see macrophages, but there is no regression. Because one of the things we have, and I did not go into more detail, that the mechanistic target of rapamycin complex 1 goes high in this model. Autophagy is down and proliferation and migration is very high. And if we treat them with gefitinib, we can see that at mTORC1, actually it's lower, it goes down autophagy and proliferation. So with that, this is the lab. Most of the work I told today was done by Misam Yazdi-Khan and 2 other postdocs who have now moved on with their own laboratories. And while I have this beautiful opportunity to present. These are the main people who work in the lab day and night to produce good data. So with that, thank you very much.
All right.
Thank you, Dr. Debashish. We have quick questions. We're running out of time. If Dr. Sinha can take these 3 questions quickly, then we can go to the next talk. And one question for Anuprita as well. Tanuja wants to know which promoter was used in the Nuke case of animals expressing CRYBA1 in astrocytes only.
So the Nucleolus is a rat, and it is a spontaneous mutation. For the transgenic we used the human GFAP promoter. And for the other one, it was a CRISPR-Cas9 we used to make the 2 different beta A3 knockout and beta A1 knockdown mice.
Okay. Second question is, does Nucleolus modulate ribosomal biogenesis as the size of nucleolus was large, and could that also be possibly altering the vessel abnormality?
So that's a very interesting question. We have not looked at the nucleus because we wanted to have one model. So now that we know exactly which protein is actually regulating the astrocytes, and we know from our studies now that beta A1 recently, me, Orko and Swami has submitted a paper on that. And so once those things comes, maybe we can do more nuclear work. And it is a possibility that there is some transcriptional regulation and which is affecting the translation of different types of the mechanism that is happening. But we do not know at this time because we have not really looked in detail.
Okay, one more question. Can I just finish the audience questions, please? There is one more question that says, can retinal tumors like retinoblastoma keep the fetal vasculature patent? Because we reported a case of congenital retinoblastoma, but did not know the exact mechanism.
This is interesting. I myself do not know because I don't know much about. Maybe Orko can say that if retinoblastoma can do that. I don't know much. Sorry, I don't know much about retinoblastoma or had read any connections between PFVs and retinoblastomas. Could be there, but maybe I did not come across anything like that.
Yeah, I think the answer would come from whether we know anything about astrocyte involvement in retinoblastoma. So there, I think we can draw some parallels. But I'm not quite aware of astrocyte involvement in retinoblastoma.
Dr. Deepankar has a question. Please unmute yourself, Dr. Deepankar.
Am I audible now?
Yes.
Yeah. Professor Debashish, I wanted to know, basically, if you see the astrocyte, the retinal in human, the retina is basically the protoplasmic astrocytes, whereas the optic nerve is a fibrous astrocyte out of all 4 or 5 group astrocytes. Now, when you stain with, for example, GFAP or for crystalline, you do a staining, or you see Nucleolus or any other staining, where can you categorize between the difference between the two different astrocytes? And moreover, another question is, if you have a cross section of a adult optic nerve, what astrocyte do you expect in the central, around the central retinal blood vessels? Which astrocyte you anticipate in around the central retinal blood vessels?
Okay, excellent question. So, it's very unfortunate. I was starting to collaborate with Ben Barrs at Stanford, who most of you may know has been one of the leaders in astrocytes, and he had before he passed away, he had actually characterized different types of astrocytes in the brain. So we actually do not know, but you are right. The astrocytes in the optic nerve and the astrocytes in the retina are different, right? Because as I showed, one of the things that intrigues us also, that in the PFV, when it is not regressing, and the inhibition, then the astrocytes we can clearly see, and even at the EM level we can see that the astrocytes are actually ensheathing the hyaloid artery, right? At the same time, the astrocytes that are in the retina, they do not, where it is function is to, enwrap the blood vessels. The mutant does not do that, right? They are leaky and they're good. So is it gaining some functions or it is changing? What is it doing? And so is it going directly from the optic nerve, or is it moving from the nerve fiber layer and moving? These are the questions we have not addressed yet. But you have definitely a very interesting question to be addressed, that what type of astrocytes is being involved in the disease. Is it the same that is coming to, because when it is coming from the neuroepithelial layer through the optic nerve to the retina, all way through, is it changing itself? We do not know what it is doing. So you are correct. I don't have an answer at this time for your question, but definitely, there is all reasons to believe that it is not the same astrocytes.
Thank you, sir.
Professor Shomi has a question.
Yes, I wanted to ask Devashish, how much of an overlap there is between AMD, where you also have leaky vessels and sort of neovascularization, and your Nuke mouse, rat, because there also you have leaky vessels and the pathology. So do you think there is a reasonable overlap between the two? And do you learn much from your work in relation to AMD?
So can I call you Mama still, Shomi Mama? So maybe I'm sorry because it's a default. I cannot tell you.
You have to ask our course question.
Okay, so good question. But here is what we know, and I don't know for sure if it is true. So this PFB work in my lab is just is not our main focus. Our obvious main focus is the AMD that we do, and very recently with Orco, we are trying to see about diabetic retinopathy. And I don't know if it is a panacea drug going to be, because any disease we see these two proteins. But I will tell you this, that in the Nucleolus rats, and also particularly in the mice where we were able to delete the gene, particularly in RP cells, because this protein is only expressed in the retina or mostly in RP cells and in astrocytes, and some in ganglion cell layer. And when we delete this conditionally in the RP cells, it does show Drusen and everything, but it is more of a dry AMD phenotype. We don't see any blood vessels involved in it, for sure. And I don't know, so I was talking about this moonlighting proteins, which is now coming into consideration, that many proteins like this, which are made particularly by leaky ribosomal scanning, they function differently even in the same cell. So in astrocytes, we have started to understand about these two proteins, but in RP cells, we do not know. So it's one of the interesting things. We are planning to submit another paper in astrocytes and RP cells, just simple, because you were talking of ABCA4 and everything, just simple phagocytosis. There is a very interesting review by Cody Ramachandran in University of Virginia, who is a very big phagocytosis guy, does not work on the eye at all, but recently has published a paper showing that the RP cells phagocytosis is completely different than any traditional phagocytosis. it actually recruits many different things to phagocytose. And we are showing that even EGFR endocytosis in RP cells is completely different and in RP cells than other things. And if this is because, I told you that crystalline is a structural protein in the lens, and in evolutionary way, RP expression outdates the lens, right? It is more earlier. So is something happened in the evolution that it retains such functions that it is necessary to integrate all these very specific physiological functions. So we do not see any wet AMD-like phenotype. What you are saying, we also thought, but it's completely different because the astrocytes do not enwrap. More or less, it has more like a diabetic retinopathy like of phenotype in the Nuke. And very interestingly, with help from Orko and colleagues there, we found that we see microaneurysm formation also in these rats. No animal model in diabetic retinopathy shows microaneurysm. I didn't know. People tell that is the only one that happens. So I believe that maybe functionally, because these two proteins are different, maybe, so they do different function which affects different regions.
Okay, so I think Dr. Jalali has a question.
Yeah, I have written it there. I cannot unmute myself.
No, we can hear you. We can hear you, Dr.
Okay,
Jalali.
I just wanted to know, was it bilateral lesions you were seeing in your model, or only unilateral?
It's very interesting question. I know in humans it's always very rare bilateral. But in the rats, it is bilateral, very rare. It's opposite. But in the mouse, interestingly, for the mild and moderate forms, we see unilateral. But in these rats, we don't see much
Do
about
we have any idea why it is unilateral in some and bilateral in some? And second thing is, does the eye size also change?
Yes.
Because in humans, the size is always smaller on the side of the...
Yeah, but I don't know. Yes, it is, but because of these proteins, I don't know, because if you saw the first slide I showed about those rats, they have microphthalmia, and even in the mouse, the eyes are smaller.
So because we do see bilateral, and bilateral we see without change in the eye size, and that we see in ROP, and we see it in a condition called FEBR, which is a WNT signaling pathway vasculogenic disorder. There we do see bilateral, and there, if the fetal vasculature is persistent, then we see very severe disease in its progression, not in its happening. So I don't know, does that correlate to more immature retina, or but there the eye size doesn't change; it's normal eye size.
Yeah, here the eye size definitely changes and it's smaller, but we have not looked into detail that it is. But yes, it is a question that has been raised previously to us, and we also think, because many of the clinicians that at that time when I was at Hopkins that I talked to, there did mention, and Dr. Goldberg was there, said that there is, but he said that there are but more unilateral cases than very rare bilateral cases. That
last question I wanted to ask: have you exposed these mutants to oxygen? Does oxygen lead to more severe retinal problem in eyes which have persistent fetal vasculature? Do they get more problem? Because you showed that the retina is not healthy in these children, in these models. So I suspect, have you tried to see whether this retina becomes more damaged by oxygen exposure?
The retina in the rats is very interesting, and maybe next time I get any opportunity and I'm in Bangalore or wherever you are, and I can send it to you. The retina is very thick at the early stages, like even at 6 months, 7 months, it is really thicker retina, because we have shown that one of these things that the gene does is that it actually inhibits also the normal cell death process. So the ganglion cell layer is much bigger because the normal ganglion cell layer death does not happen. But then after 12 to 13 months, it degenerates really very bad, and we can see all fibrosis and everything in these rats. And that happens around 14, 16 months with all inflammation and everything.
Oh, great. Thank you, Dr. Debashish. I think it was quite an eye-opener for a lot of us, especially who don't understand, this in-depth and understanding of astrocytes. We will just take one quick question for Dr. Anuprita before we start with Dr. Anand. Dr. Jyoti wants to know, can you explain how you handle the psychological aspects of counseling when you tell your patients that the disease may progress and they may or may not go blind and that there is no treatment?
Right. So, I mean, that's a very good and an important question. And unfortunately, I don't have a short or a quick answer to it. But here's what I can say, that in my experience in these 6 years, genetic counseling, it's a very dynamic process. And of course, the take home is to be given to them, which is the basic information about, the genetic inheritance pattern, the genetic disorder, and the genetic test. And the rest of the things they have to unfold, which depends on how receptive the patient or the family is that day, and whether the patient has come alone, and how much of overwhelm that it's there, and how difficult it is sort of to communicate certain things. And we don't have to really put everything in the first meeting itself. Like I said, the basic information has to be given, but these aspects can be dealt later also. And I can say this because they do come back when they get to, again, they get a breather and they get to revisit this, they do come back. Having said that, we do encourage them to seek psychological help, as when we see the kind of situation that is there. And if it is a child, then, and of course, let's say with a syndrome, then we do, with or psychological issues, then we do recommend even special needs teachers. So we do those kinds of things also in the clinic. And like I said, I don't have one right answer for that because it varies. So
changes with the situation.
Yeah.
Anyway, thanks a lot. I'm sure it helped whomever wanted to know how you go about it. Next up, we have Dr. Anand Vinekar. Brief introduction. He completed his residency and retina senior residency in the prestigious PGI Chandigarh, after which he completed his pediatric retina fellowship in Michigan, USA, and defended his PhD from the Maastricht University. At NN, he founded the KIDRA program, which is currently regarded as the largest telemedicine program for ROP in the world. And he's the founder secretary of the Indian ROP Society and a member of the National Task Force for ROP, Government of India. Today, he will talk to us about his work in ROP biomarkers using tears. Over to you, Anand.
Thank you, Chaitra. And I think today I'm going to be speaking as a sort of a clinician. And all this work is possible because of the collaboration that we have with our in-house Grow Lab. And many thanks to Dr. Swami and Dr. Arka and his team at Grow Lab. Specifically from our KidROP team, I'd like to mention Mr. Krishnan, who helped with all the sample collection. And one of our former fellows, Dr. Shivani Sinha, who's now a faculty at AIIMS Ranchi. The disadvantage of having such a good team to work with is that you end up just being the clinician, and that's going to be my perspective. Well, I think we all understand that India's ROP program is probably the biggest in the world. We have 3.5 million babies who are born preterm just annually. And if you just extrapolate that to just a minimum of about 4 to 5 exams that we need to do before we declare a baby ROP free, that's close to about 18 million examinations. And with less than 200 ROP specialists, we are looking seriously at a problem which is difficult to handle if we want to follow the exact schedule of seeing them. Now, just an example of babies whom we see in our program. These are babies, of course, we cover all the districts in Karnataka, but even then, mothers have to travel. And imagine this baby who has to come more than 200 kilometers only to be told that, no, you don't have ROP, you just have immature retina and come back after a couple of weeks. And this process continues. So if there's some way we can actually predict at the very first screening event to a good measure that this baby may actually end up developing ROP as against a baby who maybe is at low risk, imagine how useful that would be for the baby and the family, and for us as clinicians to triage better the way we follow up these babies. Unfortunately, there are no good prediction models. We've tried our hand at looking at simple things like how long it took for them to gain their birth weight and other clinical and, let's say, operational markers. Unfortunately, these have not been very good at predicting at the first visit. Once we start looking at the tempo of the disease, that's a different story. We also know from our rural work that the single most important factor why children fall out is actually the difficulty in following up. So how about trying some other prediction format? So is there a non-invasive biomarker? And that's when we stumbled upon tears. Now that's not hard to guess why. GrowLab at NN has been doing some phenomenal work with tears, especially in the anterior segment. Work from keratoconus and so on is now world famous. So we just nudged them to do some work on ROP also. And when you look at biomarkers in tears, this itself is something that has grown phenomenally in the past decade. But unfortunately, we still don't have the magic bullet for retinopathy of prematurity. So the aim was, well, we all know the common villain. We know it's a pro-angiogenic disease, at least the imbalance of that. So can we use some of the more commonly known ones and maybe some other hidden ones as well, and correlate these with the maturation of the blood vessels and the progression of the disease? Well, this study has actually been expanded, and I'm really presenting work that has been analyzed a while ago. But I just want to mention here that even though part of this presentation was done before, this is the first time some of this data is being presented in any fora. So we had about 36 cases, 23 of them had ROP and 13 of them were controlled. They were preterm controls. 18 of them had ROP at the very first visit. This is not uncommon in our scenario. And 5 of them developed it as we followed them up. And as we looking at what they went on to develop, we could reclassify them as progressing ROP or regressing ROP. Now, these are just some visuals to tell you how this is done. It's fairly simple. I, for one, was surprised to even know that these preterm babies who are just a few days / few weeks old can actually produce tears. Well, we thought tears come in many months later, and we still don't know what these are, these conjunctival secretions or some sort of excretions. But well, whatever it is, as you can see from the second, we can get columns as high as 20 millimeters. So that's what we did. And then we took these samples, maintaining a very strict cold chain to our grow lab. This was obviously stored and archived. And then they agitate these filter papers to remove out the stuff that they want to analyze. And this is done through a whole lot of process like PBS solution and then shaking it on in a centrifuge machine. These are very difficult terms for clinicians to remember, so I hope I'm doing justice. And finally, cytometric bead analysis is done, and well, we get the results for what's really beautiful here is a single assay gives out all the markers that we want to study at one time. So a really small quantity of tears is often good enough. Of course, our course team always wants us to give them more sample, but well, with the little we give them, here's the magic. So after looking at a lot of pilot data on about more than 24 proteins, these are the 10 that we kind of homed into. We know why. Some of them are very famous, VEGF, angiogenin. And then the others sort of tell the common story of ROP, where you need chemokines, you need cytokines to make that happen. And of course, you need all of these to adhere into the endothelium to give the pathology or to make it normal. Now, I'm going to present these results more like from a clinical aspect, and we are going to look at some of those proteins and how they express themselves. Firstly, and it's important to state here, because unless these are shown to be true, we won't know how well to actually rely on our results. So the first thing we want to say here is that the birth weight and the gestational ages were lower in babies who had ROP, and that's really common sense. But the more important thing is the age at which they were collected was comparable. That's really important because all the results I'm going to show you now are going to be mostly based on what happened in that very first sample. So it's really important to know that here's the baby you're seeing for the first time ROP screening, you're collecting the tear, and now whatever I'm going to tell you is going to be based on that mostly on that one test. I'm going to tell you what happens in follow-up as well. So when you look at the top one, ROP babies, and the below the ones who did not have ROP, angiogenin is negatively correlated, which means, lower levels of angiogenin as the birth weight increases. And this does not happen in ROP. There's another molecule here which kind of showed up in both the groups. So again, now our focus is going a little bit on angiogenin. Now that was birth weight. Let's look and see what happens to gestational age. In gestational age, which is again a parameter that we are dealing in and day out, it's again negatively correlated with the cases, but not in the control. So already there is some sort of differentiation here. This is a sort of time-lapse montage of babies who went, the no ROP babies, basically, the ones who went from immature retina to mature retina. And these are, these abbreviations are some of those molecules and how they played out at the very first screening. Now, with the first screening sample, we found that there was lower VEGF in infants who developed ROP later on. We had no idea of knowing at that first visit whether these babies would eventually go on to develop ROP. And we obviously looked at that prospectively, but it is interesting to know that you could predict that right here. Now let's look at type 2. Type 2 ROP is nothing but ROP that sort of comes in and then spontaneously regresses. In other words, maybe never needed treatment. And again, these are the way these molecules play with each other. Now, again, I'm going to mention here with the first screening sample, what happened here is that angiogenin, again, that molecule, was higher as the stage increased. So which means stage 3 had higher angiogenin than stage 1 and 2. We did not know which of these babies are going to develop which stage, but then there was the marker right there. As I mentioned, we had subclassified babies who were regressing, and this, of course, had to depend on their second or third visit as against babies who had progressed. So what happened after we looked at that second visit? We found that those babies who had lower VEGF and angiogenin were the ones who progressed. At this point, let's stop to think that we kind of knew that VEGF was required for normal vascularization. So at which point that tips the balance from normal vascularization to pushing them towards ROP and severe ROP maybe is not clearly known right now, but it's interesting that this is playing out at the very first and second visit. And this is the final visit, which is one penultimate to the final, where they either mature completely, as you can see in this image at the end, the ora serrata, or they have spontaneously regressed, or they have regressed with treatment. So this is that plot, which tells you that there is an increase in VEGF and angiogenin levels between their very first and their final. And again, final here would be a spontaneously regressed disease or post-treatment. Now, what all clinicians are really interested in is what happens and can you predict babies who require treatment? So that's the type 1. And well, this is a time lapse of the same baby whom we saw the very first time, which had a very innocuous looking retina and then went on to develop a stage 3 with plus disease, was lasered, as you can see, and did fairly well. Well, that's the common story. But what can we do with their very first screening samples? So the two parameters that I brought in the very first slide was birth weight, which we all get to know, and gestational age. Can we play with these two that we know? Again, not too sure because many times gestational age and birth weights are not known accurately, but can we play around with these? So what we found, that is, if we had ratios, angiogenin divided by birth weight, VEGF divided by birth weight, and so on, we found that the two ratios, angiogenin by birth weight and angiogenin by gestational age, were higher in the ROP group. Again, first screening samples. Well, if you go on to look at that, so birth weight and gestational age, as I mentioned, are not very accurate in many of our mothers. So let's use very objective data. We know angiogenin levels, we've tested that in the lab. We have VEGF levels, we've tested that in the lab, and we're sure of those. So how about a ratio looking at those two? So when we looked at angiogenin divided by VEGF, we found that, again, they were higher in ROP babies. Now we are probably stumbling into something. Now so we played around a lot with these ratios to see which of these ratios could be a predictor. For that, and of course, reach a possible biomarker. So therein comes in the magic of Swami and his ROC curves to look at what could that cutoff level be and for which ratio. So the largest area under the curve came from that vertical, which is mentioned as D, which is birth weight divided by angiogenin divided by VEGF. So that's the denominator has a ratio itself, angiogenin divided by VEGF, and the numerator is birth weight. And we came up with this number of 29. A number lower than 29 was probably going to predict that these babies are going to develop ROP later. And that's really exciting. So the impact of this study is that all this time we knew that some of these molecules played a significant role in either vascularization or pushing them towards severe disease. Well, here's the molecular evidence. And this is, of course, the first human study to look at that correlation between VEGF and angiogenin. So what does this study add? Well, firstly, it's non-invasive. You saw that. It was fairly easy to do. It can be done in the office, and it doesn't need any form of anesthesia. In fact, you shouldn't be using anesthesia drops because that would trouble the assay. Low VEGF before ROP initiation was actually associated with the disease, coming strongly with the fact that VEGF is required for normal vascularization. Again, angiogenin, which we don't blame so much as VEGF because of the whole pharmacotherapy there is also probably responsible for it. And ratios like A by V or birth weight by A by V can possibly be used as biomarkers. We hope that we'll be able to create a point of care kit where, imagine this scenario where tons of mothers are getting screened for the first time. We pick up their tears and put it into a machine like this, and we tell the mothers, hey, low risk, come back after 5 weeks, or high risk, come back next week. Just coming back to that very first baby we spoke about, imagine if we were able to predict that this baby had no risk or low risk. It would really reduce the number of visits that this baby can have, and of course help us treat these babies much better. Really want to thank the entire team at NN and especially the Grow Lab for making this presentation and all this wonderful work possible. Thank you.
Thank you, Anand. Would Dr. Jalali like to add something, ma'am?
Can you hear me?
Yes, ma'am.
Yeah, I think Indrajit should speak because she has done a lot of work on tears and biomarkers and all that stuff, and her lab does it, and I think they are also on a similar path, so that will be good. Indrajit,
yeah. Nice work, Anand, actually. It's very exciting to see. We, as you know, in 2017, we published our tier data where we have shown, we also did the similar kind of analysis like you did. And we found, interestingly, matrix metalloprotease 9. And again, we collected that at one time point and for the first visit, first screening, and then we followed up these babies. So babies who develop severe ROP, they have matrix metalloprotease levels very high right in the first, within first week of birth. And those who do not develop severe ROP or who develop regressed ROP, they have much lower levels of MMP9. I was just interested to ask.
I think you looked at also the correlation between the interleukins.
Yes,
in that paper.
I have done interleukin 6 also. But among all those, we found MMP9 to be strongly correlated with the severity and regression of ROP as well. So, and we have also recently, explained by in silico and in cellular analysis how MMP9 actually degrades opticin, and that's how it actually regulates abnormal angiogenesis in the eye. I was, just wanted to ask, did you also check MMP9 levels, and what was your finding there?
Well, in the initial study, we didn't do MMP9, but we did a whole lot of other interleukins 6 and 8, and I think Arko can help me here. Interleukin 8 and RANTES at least had a very significant correlation with the ability to predict the ROP. And again, we tried to work out some ratios. This is almost work that's ready. Well, no, we didn't look at MMP9, but I think what comes out from your work and ours is that there's a lot of inflammation.
Right.
And I think that is really the key word. And we know now we throw that word at diabetic retinopathy, we throw it at keratoconus, and we certainly know that, ROP is also inflammatory. And that opens out, I think, so many more vistas of possibly treating these
right.
babies.
Actually, in fact, we submitted that paper last month where we have shown, I think we presented it much last year at ARVO also. So when you inhibit these matrix metalloproteases actually by using doxycycline, which is already an approved drug, you see considerable increase in opticin and other anti-angiogenic molecules. So we have shown this in the in vitro assays. We have not really tried this therapy in the babies itself, but this is something that we would want to, because it is already in use. So I am not sure how it will be useful and what kind of dose would be required for our dose. Maybe you and Subhadra can tell us. But I think there is a potential there, and it also modulates the complement C3 levels. That also we have talked about in that paper. And this is all mediated by the microglia, which gets activated and moves into the retina upon some kind of trigger, maybe hypoxia as a trigger. That's what we claim. So I mean, it is interesting to see your study. Definitely, you have some interesting data.
So Indrajit, and this is a question for both you and Dr. Jalali, is that if you were to propose a treatment with doxycycline, at what stage would you give it? Because it's the same conundrum with anti-VEGFs. So you have to decide what stage you have to give it, because as you can see, if it's low in the beginning, it predisposes you to ROP, which is what is known.
Yeah. No, so definitely MMP levels are predictive markers, but what dose, that as I already told you, that we haven't really thought about it.
I was asking about the stage. What stage would you?
Because we are seeing very high levels of MMPs in the first week of birth, when they do the screening in the NICUs, and we collect the samples from there. At that stage itself, we see a very high level of MMP.
I see.
In the babies who eventually progress to severe ROP, or compared to those who have mild ROP or regressing ROP. So I think if clinicians can somehow control inflammation right in the beginning, probably this might check the progression.
So clinically, I'm little surprised that we didn't think too much about inflammation initially, although we know there's vitreous haze. Yeah. And somehow we never gave importance to that, vitreous haze or the poorly dilating pupil. We always just looked at the vessels and like, this is a vascular problem. But definitely when we operate these eyes, the vitreous is so blubbery, it is so thick. And it is really very infiltrated with all these inflammatory cells, which you have shown in the Jit. But Dr. Barakal, she gives intravitreal steroids in all her ROP vitrectomies, because she says, there's so much of inflammation. But if you see so much of MMP9, which you are saying is inflammatory marker right at birth, at that time we are not seeing any haze. The haze always comes a little later. Actually, we see clear retina with progressing ROP, and then the clinical haze comes. So maybe we need to look at little more, that is there any other clinical sign of inflammation, or that inflammation is just going to come. Maybe that would be the stage we would like to give. Otherwise, we'll have to do an RCT and see those who have high levels, at what stage of the disease. So those who have low levels you don't give, but those who have high levels, there you can start some doxycycline. I mean, that will have to be an RCT. And then see, how it works out if you give it in first week or you give it in second week. I mean, that will need to be a titrated study. But
the other problem of having, MMP is that it's not pathognomic for ROP inflammation. And at that point of time when it may be increased, a lot of these children are having other inflammatory conditions, especially bowel inflammation, necrotizing enterocolitis, and so many other comorbidities, which we don't know how much of that inflammation in the systemic circulation is getting expressed in the tears.
Right. So that will need to be studied. Obviously, that needs to be studied. Even sometimes they have viral retinitis behind CMV and all. But usually they don't show that inflammation in those conditions, actually, because they are immunosuppressed. So it's really interesting that in these very immunosuppressed babies, we are finding very high inflammatory markers even at birth. And people have said, that there is some chorioretinitis or some other inflammation which is happening in the mother, which actually causes this preterm deliveries. So, so I always say that there are two types of preterm deliveries. Maybe who know will tell more. One where everything was okay, and then because of some maternal factor, suddenly the baby delivered. But there would be a larger group where right from conception, there are genetic problems, and that is why this baby had to go. Nature was asking that this baby should be aborted and go, but we tried to survive it. So those babies may be having more abnormalities of the vasculature and inflammation than those who became preterm because of some other factor like sudden PIH or something, where their growth was good right from the beginning and only later they developed some problem. So I think it would be interesting to find out some more things related to their placenta or other inflammatory markers in the mother and systemically. But yeah, in that, just one small question. What Anand showed was that they use this, filter paper or whatever paper, but I think we were collecting tears with a capillary tube.
Yeah.
Is there a difference? Would there be a difference?
No, actually, I felt because in capillary you get much more clear tear fluid. It is and much more the volume compared to what you get in the filter paper, because then you might get some fibers coming from the, because we initially tried using those strips also, what Anand has been using, but our recovery of tear was much better when we use capillary, so we continued with capillary.
Yeah, so Anand, maybe you want to see that, because I know they use these small tiny capillary tubes which sort of.
No, I think we tried that, but I think logistically this was easier to do because this was also being collected in the peripheries.
Yes,
so,
I think this is much easier to collect. That's why we stick to this one.
Okay.
I think we should go on to the next talk, because we'll have good discussion even after that, and we'd like to wind up because we're past 2.5 hours now.
Yeah, because I have
yes. So next up we have Dr. Gagan. He's obtained his medical degree from the Postgraduate Institute of Medical Sciences, Rohtak, and his residency from Department of Ophthalmology, GR Medical College, Gwalior. He's undergone a long-term fellowship in orbit, plasty and oncology at Arvind Eye Hospital, Madurai. And his interests include plasty, oncology, and orbital diseases and treatment. And he's also been doing a lot of work with retinoblastoma. He will talk to us more about the advances that we have in management. Over to you, Gagan.
Good evening, everyone. I'll just try to be brief. I'm standing between you and dinner. We are probably running a bit late. So I'll be discussing about some novel therapeutic strategies in retinoblastoma and acknowledge work of Arka Shukra Ghosh and Vishnu on this. So retinoblastoma is, though it's the most common intraocular malignant tumor, still the numbers are too small. So it's a fairly consistent incidence of 1 in 15,000 to 1 in 18,000 live birth. And in India, we have about 1,500 to 2,000 estimated new cases per year. It is bilateral in 1/3 cases, unilateral in rest. Average rate of diagnosis in unilateral cases is more than bilateral. Overall, the retinoblastoma probably does not infuse interest because of the numbers. But one thing is with this tumor is it's only one of the few conditions where in ophthalmology a child can lose life. If you don't treat retinoblastoma, the child will lose the eye and then can lose life. So it is one of the potential life-saving conditions which we can work on, and that's my interest here. So how can we make sure that all these kids don't lose their life, don't lose their sight, and how can we preserve their eyes? Clinically, just to recap, we use different classification, commonly used classification ICRB or IIRC. We divide them into group A, B, C, D, E. And just to simplify, A is the smallest tumor you can see and E is an extensive disease. Now, one of the problems which we face in India is the different presentation pattern. So in a developed world, what you will see is group A conditions like this, small tumors, easily treatable, 99-100% prognosis, no issues. And this is what we usually end up. End stage disease, extensive tumors, children present very late to us. Even though we have plethora of treatment modalities available now, and all of us do multimodal treatment, in spite of this, the eye salvage rate in group 4 and group 5 are still not 100%. So this is a condition where I would be very happy if we can improve upon these rates in group 4 and group 5. So how can we improve this outcome? This is a thing, the questions what we have here is, can we have some better and selective targeted therapies so that you target retinoblastoma tumor better? How can we increase the enhance of current chemotherapy without compromising on any therapeutic efficacy? How can we reduce the chemotherapy dose to make sure that the local and systemic toxicity is reduced, because these kids have quite a significant chemotoxicity. And we also want to look at biomarkers which will help in diagnosis, prognosis, and follow-up, and also genetics of retinoblastoma. So these are the topics the questions which we look to answer, and these where Arko and his team come in. So just a brief background. So just a brief background of the work. So we really know in that retinoblastoma, there is a repression of E2F transcription factor. And we also know about cellular respiration, mitochondrial metabolism playing a role in cell cancer proliferation and tumor growth in various other tumors. We're also aware that when the cell tumors or solid tumors grow, they have an extra need of oxygen and nutrients. So they change the metabolic profile. So the cell inhibition does not happen and the increased requirement is met. And cancer cell can reprogram the metabolism to sustain anabolism through modification of glycolysis pathway, Krebs cycle truncation, oxidative phosphorylase redirection towards lipid and protein synthesis. So with this background and questions clinical questions which we had, we went a step further and we did a gene microarray. So this analysis was done on the enucleated tumor from enucleated eye. And if you see here in Venn diagram, we found 108 unique genes that were expressed in high-risk group of retinoblastoma. These are the samples which had high-risk pathological factors. So further on, when we analyzed the transcriptomics, we found that there's a down-regulation of some key genes involved in oxidative phosphorylation. So these are marked in yellow here. So you have SDH, SIC1, ATPase. So once we found these genes down-regulated, we thought we have to take a deeper look at oxidative phosphorylation and its role in retinoblastoma tumor proliferation. So further, in gene expression level of E2F and hexokinase, which are pathways of oxidative phosphorylation, we found that E2F2 is upregulated and HK1 is downregulated. HK1 for clinical, if you remember, we have to go to our biochemistry, remember the glycolysis cycle. So it changes, it's the first step there. It converts, phosphorylizes glucose and makes it into G6P. So G6P was the first step of our glycolysis cycle. That's where hexokinase works. And E2F2 here have their transcription activation sites, their domain, where the retinoblastoma tumor works. And then it inhibits G1 to S phase transition in cell growth. So immunohistochemistry on these cells, if you see, these are the 3 retinoblastoma tumor. Here, this is the pediatric retina which has been used for control. So if you see, HK1 is expressed in a normal retina, whereas it is downregulated in the retinoblastoma tumor. And here, E2F2 is upregulated in the retinoblastoma tumor, whereas you barely see it in a normal pediatric retina. So we again developed a tumor spheroid model where we use very one cell line to develop tumor spheroid, so which mimic our retinoblastoma tumor. And here, if you see with RB1 overexpression, the tumor spheroid shrinks in size. With E2F2 overexpression, the tumor size is increasing, and HK1 overexpression again reduces the tumor size. So this is an in vitro model. So we developed an in vivo rabbit model to study this. So we used an immunocompromised rat and injected very one RB1 cells. And after the tumors were developed, we treated them and saw the effect. So if you see here in control at 6 weeks, this is the tumor size, what you see on an OCT image in a rabbit. If you do E2F2 overexpression, you have a huge tumor, much more than the normal one, which you can compare here. And if you do HK1 overexpression, there is no tumor. So this supports our hypothesis earlier, which we've seen, that HK1 overexpression will reduce the tumor size and prevent and treat tumor formation. So in studying this, how HK1 works, we discovered a novel signaling for HK1 to LKB1. We all know LKB1 is a master kinase activator. It activates AMPK, and then AMPK acts again on the ACC and prevents fatty acid oxidation and promotes fatty acid oxidation and inhibits fatty acid. So here AMPK gave us a novel target to use with existing drugs. So we have ICAR, which is an activator, direct activator of AMPK, and dorsomorphin, which is an inhibitor. So we devised a next set of experiment to see whether ICAR and dorsomorphin can act on AMPK and hence can also act on retinoblastoma cells. So here, if you see, this is a 3D tumor which I showed you earlier. So instead of, now we are treating this 3D tumor with ICAR here. Once we treated a tumor with ICAR, you can see the disruption of tumor and significant reduction in size. Same thing with metformin. Metformin is an indirect activator, whereas ICAR is a direct activator. With topotecan, you can see a nuclear bomb. It has really killed all the cells. The topotecan, if you know, is a topoisomerase 2 inhibitor. And dorsomorphin, again, is an activator. So the tumor has become more dense, has increased in size. So now, if you remember, one more question we had, can we use this with our current chemotherapeutic regimens because of toxicity or because of having a better efficacy? So for that, we do a topotecan and dorsomorphin checkerboard assay. Checkerboard assay gives us whether the two medicines or two chemicals, what we are using, molecules, are synergistic, additive, or antagonist. So here, if we see with topotecan and dorsomorphin, the FICI value is 1.25, which you can see here, as I mentioned, above 1.25 is above 1, and it's an antagonist behavior. Here with topotecan and ICAR, we have an FICI of 0.75, which is an additive. So we do conclude here that topotecan and ICAR can work together for suppressing retinoblastoma tumor. So again, we did another set of experiments on rabbit eyes, and this is a PBS is a control group, and in ICAR is coming down, and in IPAR topotecan group, when the tumor is treated, it's again shrinking in size. So it again confirms it, our in vitro experiment in an in vivo model. So we also did a H&E staining for this, and we can see here that with topotecan at IC100, there is no tumor, whereas topotecan and ICAR at IC50 also there is no tumor. IC50 means it's a 50% concentration of normal topotecan. So at 50% concentration of topotecan with ICAR added, we have no tumor. So in summary, what we discovered is that retinoblastoma patients have reduced levels of hexokinase 1 and elevated levels of E2F2. Hexokinase 1 overexpression causes a metabolism shift, which can reduce cancer hallmarks. This is caused by AMPK activation downstream, but it's not regulated by E2F2, but done by LPK1. Retinoblastoma tumor also can, retinoblastoma cells per se, can also induce transcriptional upregulation of HK1, which further regulates AMPK and ACC, which gives us a novel target for treatment. AMPK agonist ICAR inhibits RB cell growth, induces apoptosis, and increases chemosensitivity to topotecan. We also show that retinoblastoma regulates AMPK phosphorylation via AHK1, which consequently leads to ACC downregulation. Oh, sorry, I'm repeating this one. So that would be end of my talk. Thank you for your kind attention.
Thanks, Gagan. I was wondering if Dr. Kumar has something to add. Sir, please unmute yourself, sir.
It's a good talk, Gagan. So, do you think that this will be useful in a clinical situation? Because you're going to deal with pediatric patients.
Yes, sir. It should be useful. Looks promising, but still some away. ICAR definitely looks promising.
Okay.
I think Dr. Roshmi is here, but I don't know why her tag says it's Subhadra Jalali. Dr. Roshmi.
That's also the question. Yeah.
Yes, yeah.
I don't think I can claim to be Dr. Jalali.
But that's what it says here on the screen. I don't know how it's got named like that. Dr. Deepankar, you have a question. Please unmute yourself. Unmute. Please unmute, Dr. Deepankar.
Yeah, can you hear me?
Yes, yes, we can.
Now you see these biomarkers, as you told, ICAR and MPK for RB. Now, when you show this immunohistochemistry, I would be much more interested if the mTOR protein is compared with this, along with BCL2, BCR, P56, which is a regulator of this apoptosis, as well as the aggressiveness, and P16, because this will give a clue whether the cell cycle is being affected or not. Okay. Now we see the local treatment. Already we have a topotecan. Melphalan has some complication for which topotecan is preferred. Whether the combination of topotecan plus melphalan plus the IC100 would be better or not, because you see, whatever established drug is there, now whether this drug can modulate itself or it requires some other additional drug. Topotecan with dorsomorphine, as you have suggested for this. Now, this required an extensive, what you call drug testing, particularly whatever I told, mTOR, BCL2, PCR, P56, and P16, which would give a better option for the cell cycle evidence.
Okay. So the other immunohistochemistry staining was also done for all the samples, but it's not part of this presentation. That has been done as a part for that before along with gene expression array. So it's not put into this because it was kind of understood there. So the next question is about melphalan. Melphalan has two typical issues. It's not good in pigmented eyes. So in India, you will find that melphalan doesn't work so well. West is hooked on to melphalan. Our patients have more issues with melphalan. So for us in India, most of the people will prefer using topotecan. With heavily pigmented eye, melphalan has more complication. Now, topotecan or melphalan again are chemotherapeutic drugs, so they do have their adverse effects. Now, ICAR not being a chemotherapeutic drug may or may not have those kind of adverse effects. So any chemotherapeutic drug, melphalan, even if you are using it for intra-arterial chemotherapy, can cause significant myelosuppression. So that's again, we have to realize that chemotherapy drugs are like nuclear bomb. They damage in lots of places. So even with ICAR, if it's not being a chemotherapeutic drug, if we can reduce the dose, that will also reduce the adverse effect. The chemotherapy will be much better tolerated. So it's an alternative avenue of looking for better options. It's not that it's the new option. So a combination of ICAR and topotecan might be much more mild, much more selective. That's the thing, rather than using melphalan and topotecan.
That's what the chemo, the checkerboard assay.
Yeah. Only thing is that melphalan already the retinal toxicity, the RP changes are much more with the melphalan. So no, the clinician, they are avoiding too much the melphalan. That's a very important thing because they have a significant RP changes.
Absolutely, you're right. So that is why the ICAR usage as an adjuvant here helps you reduce your IC100 to an IC50 or something, where the bystander damage to the rest of the retina can be reduced.
So you're muted.
Thank you, Gagan.
This is for Gagan.
Yes, sir.
Is this drug used in any other clinical condition? Is this molecule used in any other clinical condition?
Yes, sir. It is under experimentation, rather I should say, for variety of solid tumors. So it's not a novel molecule, but the pathway where we propose to use it is definitely a novel pathway.
Okay, Dr. Arka raised one question regarding this what you called astrocytes in retinoblastoma. That's a very interesting question he raised. Now, we had a publication where the astrocytes, can you hear me?
Yes, yes. Go ahead.
Yeah. Whenever there's a neovascularization of lens is seen in retinoblastoma, 2% of the cases, okay? And you see there is a relation between a crystalline expression, TGF-beta, and a neovascularization. So in this condition, where lens neovascularization or a anterior segment neovascularization in a enucleated eye, you can do the you can have a GFAP marker or echoporin marker or a say or Nuke1 marker to see whether the expression of astrocytes are there or not. That should be a very good
idea. Yeah, that's a great idea. Yeah,
Okay,
Roshni,
yeah, Gagan, as a clinician, I have a couple of thoughts. You or Arka can be addressing them. One is that we rely pretty heavily on focal therapy in retinoblastoma. Would you be thinking about the effect of temperature on the action of these drugs? That is one. That's one question. And the other question is that particularly bilateral tumors, we know because it's the germline mutation, every part of the retina is a potential source for another tumor. So if we are hitting it at the transcriptomase, is it a possibility that we are cutting off the tumor formation right at the beginning before it takes shape?
Yeah, so that's actually what we hope for. It really depends on where we find. So in our studies, we have found some interesting things where in our sections which have large tumors, you have other seeds also elsewhere, and then some subretinal nodule-like things which we think could be retinomas. You do see this reprogramming happening very early. So you're right that if we suspect it, maybe hitting it at a transcriptional reprogramming stage will help tide over the period during which you can develop the retinoblastomas. So once you are beyond that certain age, maybe it will reduce. So, and using a drug that does not cause too much bystander toxicity would definitely be of use for that kind of therapy. So the effect of temperature is something quite interesting. I don't know how to answer that. What we know for sure is that yes, both heat as well as cold is going to change your expression levels. The cells respond immediately to it, and you can see that also when you use your laser or cryotherapies.
Exactly.
You can see the cellular morphology, the tumor morphology changing accordingly. And you have if those therapies fail or you have recurrence of the tumor, then the morphology of the newly growing tumors are also slightly different between your laser burnt ones versus your cryotherapy ones. So that is definitely a function of the underlying transcriptional program that got reset because of whatever therapy you did. But to have a frank answer, we don't know. I mean, we know what sort of thermoreceptors and downstream signaling of thermoreceptors that work, but we don't know in the case of retinoblastoma. But the idea is that it's a proliferative program. So if you can cut off the proliferative program using some method and tide over this period of developing retinoma where you have the higher risk of probably cone precursors which are developing into the retinomas, then you have a pretty decent chance. Yes, Dr. Das, you were saying something.
Yeah, one thing, the laser, the cryo has less effect. But if you put TTT, it works very nicely because now the tumor shrinks because of transfibrillary thermopylae, where this medication or the chemotherapy works very good. It's called transfibrillary thermotherapy, TTT.
Right. Great. So
actually, there are a couple of questions for Anand's talk. Does clinical signs follow later than biomarkers? Another question is, what is the percentage of babies in which these findings were seen? I think that has already been mentioned. And another question again is, what would be the dosage and duration? Any chances of doxycycline side effects in babies? So these are all questions for Dr. Anand's talk. If anybody would like to take those questions, I think we can conclude after that.
I think I'll take the first one because the rest probably were meant for Inderjeet. Well, clinical signs are definitely following our biomarkers. That's why we are calling them predictive biomarkers. At a point of time when we are finding the assay, none of these things have actually occurred. We're looking at babies who almost all of them, except the ones who had disease in the first screening, all of them just look like regular babies, but we're finding a whole lot of things going on, many storms going on in their tears. So yes, definitely clinical findings come after biomarkers. I think the other one was for the MMP question. I think that's for Inderjeet's study. As I can answer on her behalf, they have not done any clinical studies for doxycycline, so they really don't know about dosage. And so complications of doxycycline, of course, there are on a baby, but it's used in other settings. So I think that is something that has to be a completely different study on its own.
All right, great. So I think we've pretty much taken all the questions from the audience as well. And if none of y'all have any more questions or suggestions or inputs, we can end the meeting. I must thank the audience who have been very involved with a lot of queries and discussion. All the panelists, all the speakers, my co-moderator Arko for having conducted this and planned the session so well. And also our sponsors for this webinar, NTOT, and your team, the IT team has been extremely good. We had absolutely no glitches when we conducted the entire webinar. Thanks, Dr. Shomi. I think you were a little reluctant initially, but I think you managed and you were very good with all the questions and the discussions. Thank you so much for being part of this webinar, and Dr. Debashish as well. I think Dr. Andrew has left.
So thank you, Dr. Debashish Sinha, for agreeing to give this interesting talk on PFV. We hardly hear about PFV anywhere else. So that was really key. And Dr. Dipankar Das has some interesting ideas about looking at astrocytes and in retinoblastoma. So I think we have some new ideas emerging from it. So thank you, everyone. Thank you, each and every one of the speakers and each and every one of our panelists for agreeing to be here. I'm pretty sure our audience enjoyed this. So
thank you,
good night.
Thank you, Arko and Chaitra, for organizing a wonderful meeting. It was so well done. So we should thank you. Go ahead.
Thank you so much. Thank you so much, Dr. Kumar.
Thank you. Good night and have a nice weekend, all of you all.
Thank you.
Yes, true. Thank you all very much.